Hi, good morning, everyone. Thank you for coming for today's symposium. And we are really appreciative of our both international and local faculty to make time for this, what I think is a very important meeting, because as EUS becomes more widespread, we want to be able to perform at a high level, and that's why I make the theme of our meeting achieving excellence in interventional EUS. And I hope that by this mutual sharing from our experts overseas and also locally, we can actually progress together and maybe help to flatten the learning curves for our younger colleagues. So actually, because we need to stick strictly with time, because some of our faculty they have other competing schedules. So I think without much ado, I'd like to begin the first presentation, and that's by Professor Ichiro Yasuda. He will be talking about how we can achieve excellence in our practice of EUS guided fine needle injection therapy. So Ichiro, we'd like to start the presentation. Thank you very much.
Okay, thank you. Thank you, Professor Ang, for your kind introduction. Good morning, everyone. Today, I will talk about EUS-guided injection therapy. Can you hear me? Okay?
Yes, yeah, we can hear very well. Thank you.
Okay. Okay, the history of therapeutic EUS began with pancreatic pseudocyst drainage in 1992. Since then, various therapeutic EUS techniques have been developed as shown in the slide. Among them, the first EUS guided injection therapy was introduced as celiac plexus neurolysis, CPN. The celiac plexus surrounds the celiac artery and the superior mesenteric artery, and it consists of several ganglia and connecting neural rami. It transmits sensations from the upper abdominal organs, such as the pancreas, liver, gallbladder, stomach, and ascending colon. The CPN is used to disrupt the transmission of such pain signals by injecting neurolytic agent into the celiac plexus. Initial clinical experience of EUS-CPN was reported in 1996. EUS can clearly delineate the origin of the celiac artery, and this area is a probable location of the celiac plexus. In addition, the color Doppler function assessment made the procedure can visualize the vessels. The real-time imaging guidance and the color Doppler assessment made the procedure much easy, safe, and highly accurate. Previous RCT results showed that EUS-guided CPN provided more persistent pain relief than CT-guided CPN. EUS-CPN is currently performed worldwide as a relatively popular interventional EUS technique. Until now, several guidelines related to this technique have been published. The current indication of EUS-CPN is the upper abdominal cancer pain, especially pancreatic cancer pain, because the pain is a common symptom reported by 90% of patients with advanced pancreatic cancer. These two techniques are generally used for EUS-CPN. In central technique, a neurolytic agent is injected at the base of the celiac artery. On the other hand, a neurolytic agent is injected on both sides of the celiac artery in the bilateral technique. I will show the video clip of central technique first. In this case, EUS visualizes the celiac artery and the superior mesenteric artery very clearly. A needle is advanced to point just above the celiac artery. Now needle is coming here, up to just above the celiac artery, and then inject the absolute ethanol. Okay. In the in the bilateral technique, after the origin of the celiac artery is identified, echo endoscope is rotated clockwise until the celiac artery is no longer visible, and the needle is then advanced towards the left alongside the celiac artery up to a position lateral to the point where the superior mesenteric artery originates from the aorta. Then absolute ethanol is injected into the regions. Next, after that, the echo endoscope is rotated counterclockwise until the celiac artery is no longer visible. The needle is advanced to the right lateral base of the superior mesenteric artery now, and absolute ethanol is injected again. Now needle is coming here. This is the right alongside of the superior mesenteric artery. Okay, this is a bilateral technique. Regarding the efficacy of EUS-CPN, previous two meta-analyses show that pain relief was achieved in 73 to 80% of patients with pancreatic cancer, and in 51 to 59% of chronic pancreatitis. In this meta-analysis, efficacy of the central CPN technique was compared with that of the bilateral CPN technique. As a result, short-term analgesic effect and a general risk of bilateral EUS-CPN were comparable with those of central EUS-CPN. But the bilateral approach significantly reduced the post-operative analgesic use. Several studies examined the predictive factors on pain relief by EUS-CPN. According to these reports, direct invasion to the celiac plexus, distant metastasis, and sarcopenia was factors for poor efficacy. And broad distribution of analgesic agent was a favorable response factors. Previously, a modified technique of EUS-CPN was introduced. In this technique, 25-gauge needle was advanced adjacent and anterior to the lateral aspect of the aorta over the level of the superior mesenteric artery trunk. As a result, ethanol was distributed more widely, and better pain relief was obtained than EUS-CPN technique. Later, another new technique, EUS-guided direct celiac ganglia neurolysis, EUS-CDN, was introduced. In this technique, the celiac ganglia is punctured, directly punctured, and a neurolytic agent is injected into it. Visualization of the celiac ganglion EUS is essential in this technique. Based on our multicenter study data, the visualization rate varied between 67 and 100%, depending on the institutions. I will show the video clip of this technique. First, we identify the celiac ganglia, usually between left adrenal gland and the aorta. Now we can see the two celiac ganglia here, and already punctured these two ganglia and injected absolute ethanol. It's an easy technique, not difficult. We previously conducted a multi-center RCT to compare the efficacy of EUS-CDN with that of EUS-CPN. As a result, EUS-CGN was significantly superior to EUS-CPN in cancer pain relief. However, another RCT didn't demonstrate a significant difference between the bilateral EUS-CPN and EUS-CGN. In this meta-analysis, they compared the three techniques, namely EUS central technique and bilateral technique and EUS-CDN technique. But there was no significant difference in the response rate or pain score at 2 weeks among the these three techniques. In this multi-center prospective trial, the efficacy of EUS-APN in combination with EUS-CGN for pancreatic cancer pain relief was evaluated. The efficacy rate and complete pain relief rate were higher in the CPN with CGN group combination group than in the CPN alone group. On the other hand, the adverse events rate, average length of pain relief period, and the reduction rate of opioids were comparable. A recent systematic review, including 16 studies, searched adverse events. The common adverse events were diarrhea, temporary pain exacerbation, temporary hypotension. Involvation, interestingly, involvation was specific only to Japanese studies. Their frequencies were comparable among the three techniques. They were generally minor and don't need specific treatments. Next, I will talk about cyst and tumor ablation therapy. Since the initial pilot study of EUS-guided pancreatic cyst ablation was reported in 2005, it has been performed as an alternative technique to surgical resection in selected patients. Ethanol, paclitaxel, gemcitabine, and their mixtures have been used in clinical trials. Complete cyst resolution with ethanol alone was achieved in around 30%. Paclitaxel infusion following ethanol lavage increases the complete resolution rate around 60 to 9%, 80%. Adverse events occurred in up to 24%, which included self-limiting abdominal pain, pancreatitis, cyst infection, and so on. Most recently, long-term outcomes of EUS-guided cystic tumor ablation were reported. In this retrospective cohort study with propensity score matching, the long-term outcome were compared between EUS-guided ablation and surgery. The EUS-guided ablation group showed a lower 10-year rate of cumulative long-term morbidities, lower rates of early and late adverse events, lower readmission rate, shorter hospital stay, and lower incidence diabetes mellitus. However, the surgery group had a higher complete resolution rate and a lower relapse rate. Another study reported the long-term follow-up of 2 RCTs of chemoablation of mucinous cyst. The most recent follow-up of a mean of 5 years after chemoablation. Complete and partial responses were achieved in 69% and 21%. EUS-guided ablation therapy has also been attempted to pancreatic cancer. Various EUS-guided anti-tumor injection therapies for pancreatic cancer have been developed since its first clinical introduction in 2000. However, they failed to show sufficient efficacy in early phase clinical studies. Only one phase 3 trial evaluating additional EUS-guided injection of TNF-alpha in combination with systemic chemoradiation has been completed. But it failed to demonstrate the superiority of additional TNF-alpha injection. Another indication of EUS-guided injection therapy is ethanol ablation for pancreatic neuroendocrine neoplasms, PNE. EUS-guided ethanol ablation for symptomatic insulinoma was first reported in 2006. Repeated episodes of hypoglycemia could be managed well by this injection. Since the initial reports, several studies have evaluated the efficacy of EUS-guided ethanol ablation for PNE. In a recent propensity score matched study in cases with small PNE, smaller than 2 centimeters, EUS-guided ethanol ablation was associated with fewer early major adverse events and shorter hospital stays than surgery. In addition, the long-term outcome for 10 years showed that the overall and disease-specific survival was comparable with surgery. EUS-guided radiofrequency ablation, RFA, is another option for tumor ablation. The feasibility of EUS RFA for PNEM was reported in 2015. In a recent propensity score match study in cases with insulinoma, the outcomes of EUS RFA were compared with those of surgery. The EUS RFA showed a similar clinical efficacy, a lower adverse events rate, no severe adverse events, and shorter hospital stay. Recurrence was observed more frequently after EUS RFA, but it was mostly managed by another session of EUS RFA. A recent systematic review of EUS-guided RFA and ethanol ablation for PNEM revealed that both procedures had high technical and clinical success rates. Adverse events rates were reported at 11 to 14%, which included mostly mild pancreatitis. Thus, for small PNEM, EUS-guided ablation can be a treatment option, especially in elderly patients unfit for surgery. EUS RFA for advanced pancreatic cancer has also been attempted. In this systematic review, the pooled data of technical success rate was 95%. The adverse events occurred in 13% of the cases, but were mostly mild, not severe. In this prospective observational study, 22 unresectable PDAC pancreatic cancer patients underwent EUS RFA with subsequent gemcitabine-based chemotherapy. The median overall survival, progression-free survival, and the local progression-free survival were 24 months, 16 months, and around 7 months, respectively. This study compares the results of treatment in patients receiving EUS RFA plus concomitant chemotherapy with those receiving chemotherapy alone. The mean maximal diameter of the tumor was significantly increased in the chemotherapy alone group, although it was not increased significantly in the RFA group. In addition, the RFA group had a significantly higher rate of tumor necrosis and required fewer narcotic agents. In this retrospective cohort study, EUS RFA with or without chemotherapy was performed in 26 unresectable pancreatic cancer patients. EUS RFA was technically successful in all cases. 11 cases were survived at 6 months after EUS RFA. The tumor size was significantly decreased, and tumor necrosis was observed in all cases. Thus, these results suggest that EUS RFA was technically feasible and relatively safe. However, the efficacy remains unclear because of limited studies with small sample size and insufficient quality. Okay, in conclusion, EUS-CPN and CGN has been used for upper abdominal cancer pain, especially pancreatic cancer pain, and it can be expected to have a moderate effect. There have been several reports suggesting that the effectiveness of EUS-guided ethanol or chemoablation therapy for pancreatic cysts and PNEMs, especially symptomatic insulinomas. In addition, there have recently been some reports on the effectiveness of EUS RFA. On the other hand, no effective drugs have yet been found for EUS FNI for pancreatic cancer, but recently there have been some reports on the combined effects of systematic chemotherapy and EUS RFA. Thank you for your kind attention.
Okay, thank you very much for your excellent talk. So I'd like to open, we have about 10 minutes after each lecture for some discussion between the audience and the local faculty and also the Professor Ichiro and also the other faculty later on. So maybe I just pass the mic. Anyone has any question? Okay, so I guess it's still early in the morning and there's some inertia and it doesn't matter. So maybe I'll just kick off. So in the case of, I think for most of us, what we're doing is celiac plexus neurolysis. I think less of tumor ablation by IFA or injection therapy or cis ablation. So I want to just start off by asking about FNI in terms of, I know there's a science, there's a data, but in terms of real world practice and how you feel about it, I'll just say personally, right, normally I just perform by injection of the thing in the midline. I don't really try to identify the ganglia or go left and right, simply because once I inject, there's a bit of artifact, a bit of distortion. It looks a bit hard to see. And also, sometimes to puncture so many times, it is a bit troublesome, and also I'm concerned about safety and all that, despite whatever out there is in the data. So I'd like your comment on that. And maybe Chris and Weta or Hsiu-Po can also add on to that. Yeah.
Now we are conducting the study of EUS combination of EUS CGN and bilateral EUS CPN. Maybe more effective than CGN alone and CPN alone. And yes, as for EUS CGN, as you mentioned, after injection, the absolute ethanol, sometimes the visualization of celiac ganglia is difficult, become a bit difficult after injection. So at that time, we stopped the procedure and repeated the procedure a few days later again. And also visualization of celiac ganglia. Some doctors asked me how to visualize the ganglia. They suggested that visualization of the celiac ganglia is difficult, but I don't think so. It's very easy to visualize the celiac ganglia. So you can check the area between left adrenal gland and abdominal aorta. Very frequently we can find the celiac ganglia in such regions.
Okay, good. So Chris, you have some comments?
No, actually, I had the same question as you. Yeah, I guess what I was going to ask you is before the results of your study, current study come out. At this point, do you think makes a real difference doing CGN versus just a single puncture or single injection in the midline?
Yes, previously, I believe the EUS-CGN is the best technique for pain relief because absolute ethanol is directly injected to the celiac ganglia. Must be the most effective. So we cannot visualize all the ganglia, only some ganglia. It's the reason why the effect is sometimes insufficient. So I changed the mind. Combined technique of bilateral technique and EUS-CGN may be more effective. So now we try to confirm the effectiveness.
So the midline injection technique is because the concept is that the alcohol should diffuse around the point injection.
Yes, yes.
Not only a line.
With the central technique is difficult to distribute the ethanol broadly.
Yeah.
Bilateral technique is
More you think?
suitable,
Yeah. Okay.
more wide distribution of the
Yeah.
ethanol.
Yeah. So I guess theoretically it makes sense, right? You target the ganglia until you can't see, then you do bilateral, and then you should cover everything. Yeah, but because we don't want to ask patient to come back a second time, because there's additional cost to patient, additional resource for the consumption of the hospital services and all that. Yeah. Any other comments from Martin? Okay. Okay. Okay.
Sorry. Thank you, Prof, for the excellent talk. My name is Martin. I'm one of the workshop participants here. I have little experience with this technique, but can I just ask, how do you select patients for this? Because patients with pancreatic cancer are oftentimes under care of palliative medicine physicians as well, so they can be treated with opioids, which can be quite effective. So do you only offer this technique in patients with refractory pain despite opioids, or how do you select your patients? Thank you.
Okay. That's a good, very good questions. Recently, analgesic agents are very good. We can manage the cancer pain by such analgesic agents. But at our institution, I recommend EUS CPN after NSAIDs. NSAIDs became non-effective. Because the EUS-CPN can reduce the dose of narcotic agents. So I always recommend the patients after the insufficient effect of NSAIDs. We perform EUS-CPN first, and then start the narcotic agents. It's combined.
Thank you.
Just to add to that, this issue of how early or how late has been answered actually, or has been addressed in a randomized study from the Montreal Anansa High. Quite a while ago, I think Ichiro, you remember this study also suggesting that if you start EUS-CPN early, efficacy is greater and longer lasting as well. So better patient responses if you do CPN early. Thank you.
Thank you, Chris. Yeah, you are right.
So should we?
Performance is better.
So should we do this at point diagnosis if we are clear that patient is not a surgical candidate?
I think it.
So that we save patient repeat visit. It's a one-stop service. So I'm moderator. I try to be provocative at us.
Yeah,
it's a big question.
That's a good point, because some people are doing it at the point of FNB. So if you have rows and it's already locally advanced disease, or they have already symptoms coming into the FNB, then that once you confirm that it's cancer on the rows, then you can certainly offer EUS FN, basically CPN or CGN in the same sitting, and that saves the patient some money as well. But I guess the reality is that many of these patients come from oncologists, and so if the oncologist doesn't ask for it, sometimes we, how do you, introduce this into the discussion? But certainly, I think this is the discussion maybe we should be having. I think that probably EUS CPN CGN is underutilized.
Yeah. I think so too. It's very underutilized. But I guess also adding on the point about oncologists or the surgeon, right? Because I think increasingly we see patients being offered neoadjuvant therapy, and they hope to shrink the tumor and reset. But I think most of the time actually doesn't work. They still end up having palliative treatment, but at least it gives them a hope of a potential cure. So in that sense, we probably can't do this too early. Yeah, Andrew, you had a question?
Ichiro, I'm
Yes.
Hi.
Hi.
But we have a review article in 2017, you and me. So far, I start perform CPN, CGN, because as you say, for pancreatic cancer patient, there are a lot of celiac trunk infiltration. There's a neck predictor of pain relief. And for the chronic pancreatitis, the patient compliance is very poor. So maybe they are happy in the previous 3 months, but continue, he will ask the narcotic or painkiller. So maybe as I must say, selection of patients is very important. For early treatment is very important. This is my opinion.
Yes. I agree.
Hi, Ichiro. Andrew here. I just want to ask for EUS RFA, and I think you do it for neuroendocrine tumors and insulinomas. And with the pancreas in the retroperitoneal structure, and we're concerned about the 10 to 15% risk of pancreatitis, necrosis, and further complications. Do you have any tips on how we can provide effective RFA so that we don't over-ablate or under-ablate, or any precautions or interventions you can do to reduce the complications?
Sorry, so far I have no experience of RFA for pancreatic cancer.
Is it licensed in Japan, RFA?
Yes, on pancreatic cancer, no. Our government doesn't allow so far.
Okay.
Only for biliary strictures.
Okay, yeah.
We have RFA experience for neuroendocrine tumor because the size sometimes very small, sometimes bigger, and sometimes it's the surface of pancreas, sometimes near pancreas duct. So that's in spite of many publications, the results very good. But however, for neuroendocrine tumor, we should be very careful because maybe somewhere put the pancreas stent earlier, and for the service one, we always afraid about the fistula, endoral fistula. Actually, our surgeon use the local IFA or pancreas tumor in surgical room very early. They cause a lot of bleeding. They cause a lot of fistula. Of course, they are a little blind method, not really US guided. However, we saw a lot of complication. Although the publication is so good, but actually, a real voice, I think it should be very careful about this technique.
Yeah, maybe the negative studies they don't want to publish. So we have this publication bias in real life.
Yes.
It is done.
Yeah.
Because we have two systems. One is heavy. It's a no cooling system. So this is cause a lot of, I believe, from my surgeon, a lot of fistula. But nowadays, Dongwang's system, their cooling system is much better. But we still have a case, US guided procedure for pancreatic cancer, cause bleeding and fistula. That should be careful, especially the cancer is very near the surface or contact with the GI tract. If you want to complete all, it will happen. Fistula will happen.
Maybe it's safer to do a neuroendocrine tumor, a small one, at some distance away, and you don't have to burn so much. Just have to ablate enough to decrease the endocrine effect, right?
Actually, to avoid the pancreas duct is very difficult, in my opinion, because a long time ago we have a rule of 5. You are one of the members, Group of 5 club.
Group of 5.
Yeah, we say 5 millimeter away from the pancreas. As you say, same margin for pancreas surgeon is 2 millimeter. So we change to 2 millimeter. But I think it's still very dangerous.
Yes. So I think this is quite interesting because I think a lot of time we are increasingly guided by published data because we want to practice evidence-based medicine, right? But I think we must all be aware that sometimes there's a lot of publication bias. So what we see may not be all there is. And I think for practitioners, we actually need to combine both what we see rather than just follow blindly what is out there, and then correlate back try to combine the two observations. And I think also for the younger practitioner, I think there's still a lot of work to do if you want to pursue academia in terms of how to what to do, the technique to use and all that. So I think there's still a lot of room for us to improve how we can do things. So now it's 10 o'clock, so I think we have to stick strictly to time because we have other people coming in at different point in time. So and I believe you need to travel elsewhere, right, Ichiro? So thank you very much for joining us, and we hope to see you in person very soon in Singapore. So thanks again, and I hope everyone had a fruitful discussion. So now, thanks Ichiro. We'll move on to our second speaker now. So our second session is on how we can do EUS FNA, FNB better, and we have a combined discussion presentation by an endoscopist, Prof. Andrew Kwek, and also our pathologist, Prof. Wang Lai Mun. So I think tissue acquisition is actually a joint effort, not just the endoscopist, but also we must be mindful of what we obtain and give it, provide it in a manner that can give us meaningful interpretation by the pathologist. Because if we don't give them proper thing, they can't give us a good report. So okay, without much ado, Andrew, please begin your presentation.
Which is I just downloaded the EUS FNA. It's not here. It's not here. You have a Dropbox, or maybe Lai Mun present first.
Right, I think it's better.
You haven't downloaded the thing.
Oh, you have not downloaded. You can put USB stick.
I didn't bring.
So I uploaded it.
You uploaded it. Okay, you didn't download it. You uploaded by someone. You uploaded it. Okay, so like that. Okay.
To know where the progress and the pointer.
Okay, sure. You sit down.
So this is the latest one, right?
Yeah, this is the latest one.
Hello, hi. So there's a bit of technical issue. So our pathologist will present first. So I think what we'll do now is she'll tell us what she expects from us so that she can give a meaningful report. So, all right, Lai Mun, it's all yours.
Can we do a presentation?
Yeah, I will set up the presenter mode.
Also, that by Zoom also.
Okay, here you go.
Okay, so good morning. I always like to, it's always a privilege to be invited to be on a course like for FMB by Prof. Ang and his department together with Dr. Andrew Kwek as well. Especially for EUS FNA and FNB, you can see the evolution from the time when the pathologist only get cytology material, but now that has changed to include bigger specimens, biopsy, and you can see from my slides, right? And now we are moving to the other realm of very exciting area where you have not only cytology, biopsy, but not only diagnosis. The oncologist will be asking, is there enough specimen to be sent for immunohistochemistry, for molecular? So very exciting times we are in. So this is the next slide to actually emphasize that we have moved on from even diagnosis, ancillary tests. So we are very involved in even the oncology management of the patient post-diagnosis. So in terms of adequacy, is determined by the endoscopist. The endoscopist needs to make sure that they are in the lesion itself. They are very happy that they've taken lots of material for us. And then pathologist, right, is then to examine the slides whether they are truly concur with the endoscopist assessment. Now, during the, just to some of you may not are at a trainee resident level. So just want to recap. So FMB, everyone is familiar with it. That is like your GI biopsies. That's tissue taken immediately, put in formalin fixed solution for processing. Whereas the cytology part, right, you have different mode. The ones that are that is used in CGH is the direct smear technique. This is the cheapest. Just squirt and then you just spread the slide. And if you have an on-site pathologist, on-site cytopathologist, they will be able to give you some idea whether it's adequate or even diagnostic at that time. So when sometimes you may not have a cytotechnician or pathologist on site, and if you find that it's cumbersome to spread slide, you can actually just send everything in a solution and it will be spun down by a pathology lab. Then there's the more advanced sort of liquid-based cytology that is used in cytology, gynae smears, right? Pathologists, there's mixed feeling. The good thing about liquid-based, it gets rid of all the blood, it gets rid of all the mucin, you only see very good nuclear details. But there are mixed feelings about this, okay? Because pathologists also like to have some idea about the mucin content and then also the amount of blood, the dirty necrosis. So all this actually help. So cancer or malignant or suspicious cells, the pathologists are looking for clues, what the company it keeps with to confirm the diagnosis of malignancy. So all these are different methods depending on your setup for your individual lab. So then there's the other thing that has been also mentioned as part of the sort of optimization of cytology material is the generation of cell block. Cell block is different. It's something like cytospin is spun down in the lab, but it's fixed in formalin and then preserved in a tissue wax block. So it's similar in a way to a tissue core. So the good thing about the cell block is that it can be used for immunohistochemical studies, which needs formalin fixed tissue. So direct smears, you've seen. So if the luxury of having a cytotechnician, I think all the residents who have been trained under SGH, they have a rapid on-site. So when they move out to, let's say, private practice or in an institution where they don't have, they feel a bit insecure. So they will always make arrangement for the cytotechnician to be on site. Whereas in Changi, it may not always be, and also depending on your trainer, some of them are quite happy to just do direct smear and send it to the lab. And so it depends on your individual setup. As long as there's good communication between the endoscopist, the cellular pathology department, right? How is the best way to get the most information, preserve the quality of the tissue aspirated? That's fine, okay? So what I'm trying to also say is that the tissue processing, the cytology material processing, right? Every step of the way is actually there available to make sure what you get, we will be able to give you the most information out of what is being aspirated, okay? So usually when this cytology material is being aspirated, two will go into what we call the air dried, and it's put in alcohol fix. That's for PAP preparation. So that one needs a bit of time. So the pathologist will look at it the next sort of immediately if it's available, or else the next day, right? So, but what you get as immediately is actually stained by Dhir quick. Now the problem with Dhir quick, everything gets blown out, everything looks very malignant in the inexperienced, like say young pathologist starting, right? So there's always some pitfalls. So that's why we always say preliminary provisional diagnosis at that time of the rapid on-site assessment, but PEP is actually the best for nuclear details, so always wait for the PEP. So that's why you hear read on your report 2 alcohol fixed and 2 air dried and 2 Dhir quick. Okay, so this is a flow chart of what you can have: direct smear, then have it in some liquid material for the liquid based cytology or cell block, and then the cell block will then be very similar to your tissue block. So cell block was done by a good friend of mine from the UK to actually confirm that it's actually similar to a tissue block, and it's good for comparing between, let's say, one pathologist to another. Whereas cytology material, the spread, right? You look at one slide, it may not, the other pathologist may not be able to confirm the same type of cell, and then once broken, it's lost. And I can tell there are 1 or 2 occasions where the slide fell, and then I roll my chair, and then it's cracked. OMG, you know, that's actually bad. But things may change when the digital pathologist system gets better, improved over time. So maybe even the glass slide will be scanned, and this broken slide issue will not be there anymore. So to move on, then whether cell concerns for pathologists into the tissue cell block is that whether you lose the mucin content. But good friend Newton, right, he actually have written to say that, I'll just show some slides. But this one was actually history. So it's a very good history of the endoscopic report, right? So it's a well circumscribed cyst in a woman, septation is seen, and then I like the word possible communications, but when you actually see the endoscopist writing possible, that means there is versus none. So if they don't see, they don't write down. So when there's a communication with the main pancreatic duct, is likely to be IPMN, and then they say there's some 7 mils of mucoid fluid, and it's sent for cytology. So it's done by a 22 gauge procore needle. There's no tissue-based, no biopsy done, it's only cytology, direct smear. And what I have is some cyst debris. So I don't see mucin anymore because that has all been aspirated. And pathologists now cannot rely on mucin to call IPMN. So you have to look at clues like some cystic foamy cyst debris and then foamy macrophages. And this is quite a good one where you see columnar lined mucin containing cells here, and they are all kind of in 3-dimensional, so it's a dysplastic atypical ones. So you actually combine all the information you have been given, so it's consistent with IPMN. So this is what I'm trying to document. So direct smear on a normal test, mucin is very good clue. So when I say this is a mucinous cystic lesion, on a cell block you do need the microscope to confirm the presence of mucin. And Newton has also just confirmed, done a study to say that mucin is seen on direct smears equally on a cell block preparation. So this is one that I find that even as a pathologist, being in the endoscopy room is very helpful. So this was a history given to me at the time, was a 54-year-old man. He presented with gastric outlet obstruction. Initially, the MRI and the CT scan show suspected lesion in the head of pancreas. Could be inflammatory, could be cancer, cannot be excluded. So in the room itself, so I was able to follow quite through was that the body and tail looks okay. The body of pancreas is quite irregular, edematous. In fact, the endoscopist himself does say, very vague. It seems vague, not very, it's not a typical head of pancreas tumor lesion that has been encountered before, but as an obstruction is always quite concerning for malignancy. So what I saw was okay. I see some neutrophils, look like a very dirty background. Then there's some suspicious like looking cells, look a bit atypical. And the next one, higher magnification, you see some columnar or cuboidal cells, but the background is dirty. So we're thinking things like pancreatitis, right? Pancreatitis, I'll be expecting a lot more necrosis going back in the background, but I'm not. I'm just seeing blood and some dirty bag. So dirty necrosis things, you think about cancer. So what did I tell? I said, cancer also cannot be excluded. Let me work on it when I am back in the lab. So the PET stain comes the next day. What I realized that what I'm seeing in the Dhir quick was the, let's say, ductal epithelial cells that was a bit jumbled up, as in mixed with the inflammatory cells, which is predominantly neutrophils. Now, on the PET, I'm able to appreciate the lobular acina. They were all intact. So this is technically not a pancreatitis, right? The acute pancreatitis. FMB, even though it's very clean, very bland, you can see all the lobules of the pancreas acini. That means it's not inflamed. There's no chronic inflammation like plasma cells, IgG4 is negative. So putting together, so we're dealing with a sort of pancreatitis, but it's not acute. So we're talking about the type 2 pancreatitis here, where actually the neutrophils will be the main inflammatory cells and what we call the granulocytic lesion, okay? Epithelial granulocytic lesion versus lymphoepithelial lesions. This is granulocytic epithelial lesions, and they actually is more ductocentric. So you'll see that when the FMB come out, right, the lobules, which is the pancreatic acini, which is only affected in type 1, which is IgG4, is completely normal. So when you're actually aspirating or biopsy, you may not be able to capture the duct where the lesion is. So this is a diagnosis. First of all, it's rare, not so common, but also in a diagnostic level from a FNA point of view, FMB is also difficult. So you need all this information. And I find that to make a diagnosis as such, right, the fact that I was in the room, it has really helped. Also, I would just write, neutrophil seen, some atypical cells, cancer cannot be suspected. Cannot be excluded. So you can actually see how this has left. And I've just got feedback from the clinician that patient has improved dramatically after steroids. Okay, so it's well. So he went on to be go through the process of excluding IBD because there's an association of type 2 pancreatitis with IBD. So it would be nice if you don't have the pathologist on site, is to make sure you do have EUS report. If not, right, the pathologist have access to your endoscopy reporting system so that he or she can actually capture all the information required. But I've shown you one very good example of how the endoscopist document the nature of the lesion, the size, where it's normal, where it's not, and also where the needle has been punctured to get it. Because for cystic lesions, right, whether you have gone transduodenal and then I see gastric, then it's abnormal. So that means it's more like a atypical gastric epithelium of a mucinous cystic lesion of the pancreas. So, and then the root, and sometimes the knowledge of the needle also help. And good work done by CGH 2023 is that you'll find that most of course, like all EUS services is mainly pancreatic lesions, and the predominant diagnosis is adenocarcinoma. There are a few atypical ones, but that's because our endoscopists do go through some unusual sites as well. So that's the one that the cases where the experience and also the location where the technical issues, right? So these are the report that I've given. But if you just look at solid pancreatic lesions, of course, we are doing very well. We have looked at type 2 pancreatitis, and type 1 pancreatitis, right, is this great example of a 57-year-old man presented with obstructive jaundice. That's a head of pancreas mass and presented with jaundice, right, obstructive jaundice. And then after starting on steroid, he has actually improved. And then, so I did not show the aspirate because the biopsy was done. It's done. You can see the amount of tissue that you get is actually much more substantial compared to a GI biopsy. And it allows me to even appreciate that this is an inflammatory process that spares the duct, only affecting the lobules. There's a lot of chronic inflammatory plasma cells jumble up, so you can't actually appreciate cannot see the normal pancreatic acina anymore. And then IgG4 is positive, and you get the ratio doing an IgG. So you can have lots of tissue for immunohistochemistry study, and you can make a diagnosis or at least suggest that it's a type 1 autoimmune pancreatitis. Now, the next case is not of the pancreas, but a stricture in the upper esophagus. You can see it's done by a 20 gauge pro-core needle. The quality is quite good. It's 1 cm, lots of spread of slides for direct smear. Pap stain. And you can see the nuclear detail of Pap stain is actually very good. As you can see that there are nuclear pleomorphism from the small to the larger cells, some gland formation. Well, the good quality biopsy, you can see the amount of tissue available. You can even see it in the background that is invasive into some fibroconnective tissue. As poses loss of material for immunohistochemistry, confirming that this is a metastatic lung lesion, lung primary. Okay, so another case of a, this one is actually done, so it's good that the endoscopists have actually labeled that this has done from a trans gastric approach of a neck of pancreas lesion, very small. So the FMB was done using a 25 gauge. So you can see the amount of tissue gets is less than 1 cm. 2 passes made, but it doesn't matter whether it's big or small needle. Getting good diagnostic material is still very good. It's excellent, right? As long as you hit the lesion and then it's a solid lesion. You can see this is a neuroendocrine tumor. That is typically buzzwords for histology will be mononuclear, monomorphic. They look all the same in a way, and then with a pink cytoplasm. Confirmatory will be chromogranin and synaptophysin. The reason why I do beta-catenin for pathologists is to make sure that we are not dealing with a solid pseudopapillary tumor, which is neoplasm, which is a mimic for neuroendocrine tumor. And even though it's not recommended to do a Ki-67, we still do in case it turned out to be a higher grade neuroendocrine carcinoma. So we do Ki-67. If it's a low grade, please also, well, maybe you don't have to advise, but it's more the pathologist will also repeat it again on the resected specimen to make sure we are not missing out on a higher grade. Now, finally, back on the most important part where the molecular comes in, that your good tissue acquisition, not only for diagnosis, but for precision medicine. So this is taken from a 20 gauge pro-core needle, 1.5 cm good core, and it's sent for histology, cytology, and histology. So you can see the atypical cells, gland formation in desmoplastic stroma, more of it here, and all to confirm it. And it's reported as adenocarcinoma. You can see the gland formation here, pleomorphic cells. Now, in terms of the direct spread, it's not as, of course, not as good as the biopsy material, but you can still make a good diagnosis of adenocarcinoma. Now, this is to show that there is, for the pancreas, there are a lot of molecular signatures that actually favors benign to malignant when you actually send off cyst fluid. But when you compare, right, there are studies already to show that cytology material and the tissue core and even the resection, they get quite good diagnostic material in terms of actionable mutations. And when you ask, it's quite surprising when I get phone calls from endoscopists, is that 100 cells of the aspirated material? Okay, I said that's the reason why, because a minimum of 100 cells, right, is the basic one for NGS. So again, talk to your pathologist, and then a pathologist will work with the molecular pathologist to actually recommend maybe suggest to the oncologist which is the better platform for a low quality material, and whether we can combine all the cytology material, even if you don't get enough tissue on the core biopsy, which happens. So once, that's another issue that I have pointed out, is that sometimes you have a rapid on-site. The cytologist say, oh, cytotechnician, pathologist actually, oh, we have good material diagnostic, okay. So what happens with endoscopists? They will try to get the FMB, but then they say, oh, I've got diagnostic material. You will find that the biopsy often or not, right, is never as good as the cytology. Okay, that has happened actually in about 30% of cases. Cytology, lots of material, but then the biopsy actually is quite disappointing. And that's because maybe perhaps the older generation, right, they are more used to cytology, and then once they have that diagnostic, they just forget or switch off. Okay, now next case. So, but it doesn't matter. From these studies, actually from the European work group, right, they have also looked at even if the formalin fixed tissue doesn't have enough material, doesn't have diagnostic stuff, we can actually sacrifice the cytology material and send for NGS. You just need to liaise with the molecular pathologist on site. Okay, so take home message is tissue cell block is another way to prepare if you don't have a direct smear or depend on your lab setting as well. And then finally is FNA. FNB has already moved beyond diagnosis. We are working closely with all the molecular pathologists and oncologists to actually deliver precision medicine. Okay, thank you.
Hi, good morning. Yeah, sorry for the delay earlier, and thanks, Lai Mun, for very insightful presentation. Good morning to all, and welcome to our workshop. My personal thanks to Prof. Wang also, coming all the way from Taiwan. Welcome to Singapore and our unit. So today I'll be talking about basically achieving excellence in EUS FNA and FNB, which is probably what most of us are already doing now for solid lesions. From a historical perspective, EUS has come abroad since 1980s, and that was when we were still using fiber optics. You can just imagine how difficult it was to do a EUS with your eye very close to the optical finder, but thankfully now we have video endoscopy with CCD chips. But even throughout the years, no matter how good the diagnostics are, tissue is still always the issue, and tissue diagnosis is paramount to any management. And with current technology, especially with the biopsy needles, diagnostic rates have improved and it's effective. So in considerations on when we do EUS FNA or FNB, we need to understand what are the clinical indications, how do we select needles, and what are the best evidence-based techniques. So the usual indications are for cancer, benign diagnosis like even infections or sarcoidosis. And common sites can be anywhere in the GI tract, either in the luminal wall or adjacent to it. Contraindications, of course, are many, and we have to be careful, especially in terms of causing complications. So things like coagulopathy, lack of cooperation, high risk for sedation, these are particular concerns. So going into the meat of my presentation today, we'll talk about technique, types of needles, how we can improve diagnostic accuracy, the common adverse events, and a little bit on specimen preparation in addition to what Prof. Wang Lai Mun has expounded on. Okay, so in terms of technique, so we can use straight or angulated approach. Sometimes when we do from the transgastric approach, the scope is very straight and there's good movement. If you're doing from the duodenum, scope may be angulated, needle may be difficult to come out. Look at lesions, things that are solid looking or whether they're cystic looking may also determine what kind of needles you will use, whether you also give antibiotics as prophylaxis. You need to Doppler to make sure that we don't FNA through very medium to large vessels. And of course, we need to align the lesion to the path of the needle to make sure that we get as much tissue as possible. Try to avoid excessive scope tip or elevator angulation, which may impede the movement of the needle. Now, most needle devices have actually similar components. Essentially, there will be a hollow needle where you can pick up the tissue. There will be a solid removable starlet inside. Whether to use it or not, I'll talk about it later also. There is a semi-rigid protective sheet to allow the needle to pass through your scope and lumen well. And then there's a handle. So these are just the basic components. Now, when we look at the needle types and basically the needle device, when the needles first came out many years ago, it was mainly the manganese needle type. So this is basically the non-biopsy needles. Later on, there are so many different types of needles from various vendors. This will include those that many will be familiar with, like the Procor needle, which has two types now, the reverse bevel or the forward bevel ones. There's also other biopsy needles like the Acquire Shark Core, where you can see that the tip of the needles have more like a gripping kind of dimension. So this can be Francine or fork tip types. And they have all various sizes ranging from largest, the 19 gauge, and smallest, the 25 gauge. So with so many different types of needles, different sizes, which ones should we use and which ones are the best? There's just a few things to consider about. Of course, the newer needles over the years, if you can see from the last 1 to 2 decades, the diagnostic rates actually have improved. So because these biopsy needles allow us to obtain small pieces of tissue core. So most of us will use biopsy needles for solid lesions, and then the non-biopsy needles for cystic lesions. Sizes to use is variable depending on the site of the lesion, but typically the biopsy needles may be a bit more difficult to puncture through if the tip is angulated in the duodenum. So for solid pancreatic lesions, for example, pancreatic adenocarcinoma, where they tend to be fibroblastic and there's a cirrhotic component, right? The tissue may be difficult to come in. Studies have shown that the smaller the size of the needle is, the better the diagnostic rates. So 25 gauge is typically the recommended size. And then there's no superiority of the larger needles over the smaller needles. If you're talking about FNA, so these FNA needles. In terms of puncture method, this is typically what we do, the fanning method. And fanning method basically means you try to fan through the lesion, going from the top to the bottom and to and fro multiple times. So each time, when we say a single pass, is basically, it's not the to and fro movements, but every time we puncture the lesion and we go to and fro, that is a single pass. So the needle path can be altered using either the up-down dial or the elevator. Yeah, and although this technique does not actually improve the diagnostic accuracy, but it's been shown that we have a lesser number of passes to establish a diagnosis. So possibly less traumatic and injury and bleeding. Now for small lesions, it may be difficult to actually pass through the lesion well. The lesion may just stick to the needle and then it just go in and out together with a needle. Then I typically use the door knocking method, where we would limit the length of the puncture using the stopper, and then with rapid inward movement and out, we try to get some of the tissue into the needle. How about suction? So do we use suction all the time? So suction can be given by a negative pressure with a 5 or 10 mil syringe using air or saline, or you can also use the capillary pull technique by removing the starlet slowly. It increases tissue yield, but because of the suction, it may also draw in more blood and there may be contamination. But it typically will improve diagnostic yield in fibrotic lesions such as in pancreatic cancer. So typically it's advised to be used for pancreatic masses, but try to avoid in lymph nodes, which can be more vascular. How about starlet? So the starlet, that solid piece of metal that you put into the needle, it provides stiffness to the device and also prevents clogging of the needle with digestive wall tissue. But actually, some studies have shown there's no added benefit in terms of diagnostic accuracy or cellularity, you know. So I typically nowadays, I would not use starlet for my second pass. So once if going for a second pass, I'll ask my nurses not to put in the starlet again because it's labor intensive, time consuming, and there's no additional benefit. But when after we've taken out the needle and we want to express the specimen, we'll put the starlet back again so they can have a controlled expression of the specimen. So in terms, there's also been some comparisons in terms of how do we optimize the FNB needle type, whether we should use stylet retraction, suction, or no suction. So when they compare the various biopsy needles, so for example, the Procore needle, one can probably just use suction. For Francing and Fork tip, then you can use stylet retraction. But typically, I think based on your own experience, you probably have to decide what is best for you and your performance. So just a summary of some of the methods to improve diagnostic accuracy. So selection of needles. While FNA needles can be relatively easy, it may not be able to pick up sufficient material. So for solid lesions, we usually use FNB needles, but sometimes it can be difficult to puncture, and it's of course a little bit more costly. For puncture methods, although there's no consensus on the best technique, we typically would do fanning, and then I'll do door knocking for small lesions that tend to be sticky to the needle tip. Suction-wise, I would typically use air suction, vacuum, negative pressure. But if the first specimen tends to be bloody, then I may revert to either no suction or just a slow capillary pull. Number of punctures, this can be variable, but most times usually either one or two passes. But if you find that from your own assessment of your slides and there's not much, then you may have to do more, although beyond 3 or 4 passes, it may be there may not be any value in that and may just cause more problems. Ancillary imaging studies like contrast enhanced EUS or elastography may not give us the tissue, but it does provide some confidence to us as an endosonographer on whether this may be a benign or malignant lesion. And at your own center, you probably have to decide whether ROSE, that means the rapid on-site evaluation by a cytopathologist or cytotech is a feasible thing for you and your center. But of course, it can be time and human resource consuming, and it may add costs. Or you can just rely on the macroscopic evaluation. That means you do it yourself, you look at the specimen, you see whether you get a tissue core that's more than 4 millimeters with good diagnostic yield. Other sample processing methods like liquid-based cytology and genetic analysis, that may be a post-procedure kind of advancement that you can consider. Adverse events is quite simple to consider. We normally just counsel on an average rate of 1% for most complications. And take into consideration your angle of approach, where the lesion is, try to avoid vessels and pancreatic ducts. Yeah. And to reduce complications, consider antibiotic prophylaxis for cystic lesions. Probably avoid even puncturing these cystic lesions if if there's no value in the results, for example, in mediastinal cysts or esophageal cysts that are most likely benign, so no point really puncturing them unless you're concerned about some infection or some non-specific features that make maybe a more complex diagnosis of malignancy. Coagulopathy check should be considered, especially if patients have a history of bleeding disorder or liver disease. And we typically would avoid FNA in patients who are on oral anticoagulation or thienopyridines like clopidogrel. And also we avoid puncturing cystic lesions on those who are on aspirin. Nowadays, we don't use the US-guided true cut biopsy device because it's pretty rigid, especially when in the transduodenal approach, it can cause a significant risk of perforation. So very quickly now on just a little bit on preparation. I think Prof. Wang Lai Mun had already talked about it. But this is just an example of when we do a macroscopic on-site evaluation, and this is a specimen we get for a biopsy needle. Sometimes you may see a little bit of a white tissue core, and we try to separate it out from the blood clots that you see. We pick it up into the filter paper and put it into a formalin bottle, and that can be processed as histology. So quick tips for endoscopists would be to aim for a smooth smearing spread, and that is mainly to try and bring the specimen into a monolayer spread of cells. If it's very thick, the staining, and after the staining, the pathologist will not be able to see through the multiple layers of cells. If you pick up if you see any visible tissue fragments, you should pick it up gently with a toothpick or with the needle itself and place on a filter paper and place into a formalin bottle. And we don't actually see any tissue fragments, and we're not confident with the cytology, and we actually want tissue for molecular analysis and all, then we need to do additional passes and then put those aspirates into the formalin and send it for cell block. I typically place all my cytology smears into wet fixation, that means in alcohol. But I do want to ask Lai Mun some questions later about putting some into dry as dry slides. And then of course we work very closely with our cytopathologists on best practices for our own center. There's last year there was an Asian EUS group consensus guideline, so can pick it up on digestive endoscopy. And to end, so we talked about FNA and FNB, know the indications, exclude contraindications, use the best needles and techniques, and preparing the slides is actually very important, yeah, to ensure that in the end we get a good diagnostic yield. Thank you.
So we are running a little bit of short time, but I think this interaction discussion is actually very crucial. So we'll just extend this a little bit more. So maybe Andrew and pass to you.
Yeah.
Instead of 10 minutes, we just have 5 minutes of discussion.
Okay.
Anyone? Any questions from the audience first?
Thanks, Professor Wang. Teach me a lot. And I have one question is, clinically, we think the patient have IPMN with malignant change. So patient will have to get the tissue because patient may be too old. The chemotherapy is the only way he can receive. So, but our pathology always cannot give us cancer. They say there are no trauma image. And clinically image, we can see the electron image. We can see even the metastasis. But you cannot make the diagnosis of malignant because the public growth, maybe cancer only limited to some part. We cannot really see. So is this happening in Singapore? or is any other suggestion? Because this make we very trouble.
Of course, that happens. It depends on the suspicious nodule, whether it's easily accessible and whether even the endoscopist is confident in actually puncturing it to send. And then for biopsy, it's actually easier for, let's say, okay, for a very exuberant IPMN where a lot of apically proliferation, that one is very difficult on cytology and also biopsy. Okay. But in the ones that can actually do, you must actually have the desmoplastic stroma, and that is what your pathologists are looking for. So if they don't see and they know it's an IPMN, they will say high-grade dysplasia present, cancer cannot be excluded. That's as best as they can push it for you. So then, of course, then there's the NGS that they actually recommend. So if they carry all the KRAS mutation, you will just have to then treat it as a adenocarcinoma rather than IPMN. So I think that is why all this NGS is all coming in to actually help make the diagnosis, refine the diagnosis, given the limitation we have on histology. Because from a pathologist point of view, you do need the desmoplastic stroma for invasion, especially for IPMN. It's okay if it's not IPMN, because if it's just like I say tumor mass, not IPMN, so any sort of dysplastic epithelium is cancer. Okay, but in an IPMN setting, right, there's a high-grade dysplasia, and then you really don't know whether it's actually infiltrating the stroma or not. So this is the situation where we have colonic polyps as well, where whether there's submucosal invasion, whether it's still carcinoma in situ or is it true malignant, it's the same thing. So that's why the knowledge, if the pathologist, that's why you actually ask yourself, how come the tumor mass you can actually call it cancer, but when it comes to IPMN you cannot. Because IPMN, the whole mass is actually dysplastic epithelium. So for pathologists to call it malignant, you actually need the desmoplastic stroma, and that is our limitation. So I think that for those cases, I think if the resources permits, right, is to go for NGS.
So not just Taiwan. I wanted to ask you, because we have like more than 170 doctors connected remotely. And most of the countries in the region don't have access to cytopathology, which is special skills, special board certification, making a diagnosis from small clusters or even individual cells. And also we know that the last maybe 5 years of studies are showing that FNB with a core needle, with a core needle is as good as FNA plus ROSE or rapid on-site evaluation. Can we just do away without cytology then, and then just submit everything in cell block? Because then a regular histopathologist can process that specimen and give you a good answer.
That was what I was showing also with what Newton, my friend, study was also going to show, is that you aspirate everything and put into the material, and then it be sent off and processed as a cell block material. So that one can be used for IHC. It's the same, and any general pathologist can do that as well. But from my experience, it very much depends on the endoscopist's skills. Because I find that some are better, and then don't forget, especially in the area of pancreatic tumors, is cystic, solid cystic. So I sometimes also find value in the aspiration material. So I wouldn't say one replace the other. If you have the luxury of having a cytotech and a cytopathologist, every part is so important, and that's why some of my cases have highlighted that whether it's the aspirate has helped, then you have the biopsy to help. Even in a negative biopsy for the autoimmune type 2, right, it has helped me greatly. Okay, even in a negative setting, but my aspirate was the one that was actually, I call it self-suspicious, cannot exclude. But then when you look back, when you put together all the clues, right? So if you don't have a cytotechnician or a cytopathologist, then you have no choice. But if you do, please use the services available to you. Okay.
Just a quick question, just from a practical aspect. When we are fixating the slide, is there a difference between the air dry and alcohol? How do we choose which?
What I meant by air dry is the air dry is actually used for the dip quick. And then the alcohol fix is used for pack. Okay, so when you put it in the, and it will be actually all dealt with in the lab. So there's not much difference, it's just different preparation and for different staining. Yes, and sometimes there are spares ones, if you can, to send off, again, we can do some stuff with it if we, if I break a slide.
Okay. Any other questions?
Should I have a question? Now, what we do is nowadays we have been pushed to the gene profile screening or NGS. So the EUS FNA or FNB, when we done the pathology, not pathology, the oncology and the surgeon will always want to have NGS. So what is your suggestion in your experience? How much tissue we have to get? Because before we puncture as we can, then we have a rows or evaluation by ourselves, we decrease the puncture. But nowadays we have to get enough tissue because the tissue core non-miss can be available for NGS. So in your experience, how can we send adequate tissue to pathologists?
Actually, if you send, for the examples that I've given, right, it's actually, because when you're doing the FMB, you're actually in the tumor itself. In a very good technique, usually you have enough. In fact, you will see the examples that I've given, right, they're actually much bigger than the endoscopic mucosal biopsy for gastric cancer, and those also have been used for NGS, and it works perfectly. So for this, the pancreas, right, I think the FMB material has never been an issue. And if the situation that I've given you is that, oh, the endoscopist actually have lots of material on the cytology, but none on the biopsy, you can still use the cytology slides. But you have to actually let your pathologist know that, oh, since there's none in the tissue core, what about the cytology? And then the cytology, can we sacrifice those? And
So I guess the question is, what's the minimum volume of tissue needed for NGS? And that I guess that depends on the sensitivity of the test, and I guess things will become more and more sensitive, and therefore we need less and less tissue.
You know, some the ion torrent, or so the different platform. So again, you have to really communicate with the whole. In fact, some stuff like this really need a MDT discussion among the different subjects like the endoscopist and also the oncologist and the pathologist together, whether there is enough material. Yeah. So far, it's been okay.
So I guess that would mean that we need to actually talk to our people doing the NGS to see what equipment they use and what's their sensitivity, because depending on the equipment they use to sequence and all that, there's you may need more or less material. Yeah. Okay, good. So I think now we move on to the next speaker. That's Professor Wang, who will talk on excellence in pseudocyst drainage. Yeah. Yeah.
Sorry, my voice is terrible, so I refined my video this early morning. I hope you can tolerate. gentlemen, and good morning. Thanks, Tim Yong, invited me to attend the AEG Interventional EUS workshop in Singapore. Today, I will speak on achieving excellence in EUS cirrhosis drainage. First of all, I apologize and appreciate your patience with my hoarse voice. Clinically, the patient may suffer from acute complication of hepatitis or after with cirrhosis. Even more severe, effective nicotizing correction. To make the proper terminology and the clinical management, the Atlanta classification for correction related to acute hepatitis had undergone several revisions over the years. Division of 2012 local complication include acute peripancreatic fluid collection, cirrhosis, acute nicotizing correction, and warm. The key point is to use experience as a dividing line in time. Cirrhosis is defined as calculated correction rate with a well-defined formidable, usually outside the pancreas with a minimal or no necrosis, occur more than 4 weeks after onset of pancreatitis. How often will the cirrhosis occur after severe pancreatitis? Following severe pancreatitis, only 15% of acute pancreatic recollection will progress to form cirrhosis. In addition to acute cirrhosis, chronic cirrhosis that occur in chronic pancreatitis also require treatment. In addition, cirrhosis and or necrosis may be complicated by infection. So the first question is, to all the case of severe pancreatitis complicated with the pancreatic collection require intervention. According to the published data, approximately 60% of acute cirrhosis, they are less than 6 centimeter size, will resolve on their own and do not require treatment. Cirrhosis that are 6 centimeter or larger have a high risk of developing complication. However, some studies have shown that cirrhosis can remain asymptomatic because of their size or how long they have been present. Intervention is required only when symptom or complication occur. Infection or symptomatic steroid patient to worsen abdominal pain, tracheostomy, tissue absorption, or symptom caused by rhinosinusitis due to documented cirrhosis rupture. Treatment of very poor correction. Compared with surgical drainage, the AEG 2020 guideline suggests endoscopic drainage or surgical drainage of symptomatic chronic cirrhosis. As shown on the timeline, conventional endoscopic treatment began 50 years ago. The conventional endoscopic drainage was introduced 40 years ago. EUS drainage has been used for over 30 years. From the past to the present, endotherapy for pancreatic cirrhosis include transfibrillary stenting, conventional endoscopic drainage, and the EUS drainage. Transfibrillary stenting involves calculation of blood artery into the pancreas, then guiding the wire through the cyst. Finally, a stent is placed either near or into the cyst, or bridging the disrupted site of pancreas. The conventional endoscopic drainage is conducted only when there is a large hole due to the compression by a cirrhosis. Pre-puncture with cold needle line, and take out the needle and the guide wire through the needle or the catheter into
to the septic cavity. Check dilatation with balloon dilator. Insert the blood stain subsequently. All the procedures are under fluoroscope guidance. Compare conventional with US guided drainage. The conventional drainage have shortcomings of endoscope visualization only, and the visibility of vessel limited. And the system must barge to the GI wall, high risk of bleeding or operation. On the other hand, US guided drainage allow real-time intervention and drainage of aqueous connection. Also provide assessment of size, location, wall thickening, and content of this region. US guided drainage can used for those that do not compress the abdomen, and also allow the identification of any intervention vessel before puncture to avoid major hemorrhagic complication. Therefore, I recommend US guided drainage over conventional endoscope drainage. So US guided intervention has been in an important position to treat the medical connection. Among the US procedure, US guided pseudocyst drainage is defined as the level 2 procedure if conducted with blood stem in Taiwan. By using names, is classified as the level 3 procedure. Familiar with the US guided pseudocyst drainage is a prerequisite for other advanced interventional US procedure in Taiwan, such as the EUS-GJ and others. Please share the information about US training in Singapore. US guided connection is classified as level 3. Next, I will speak on how to perform the US guided pseudocyst drainage. First, we have to avoid utilization or connect the drain, such as puncture distance, the many vessel, or near present. We can use contrast US or check the appearance of aspirin. The wall-to-wall distance of less than 1 centimeter is preferable. Though some lamps have central lengths exceeding 1 centimeter. The case of repeat years after US guided pseudo drainage with a plastic stem, the stem have a considerable wall-to-wall distance. Although it did not penetrate a small bowel. However, it reached the bowel without edema and obstruction. And the symptom will improve after a stent was removed. It is very important to identify any intervention based on or puncture to avoid major hemorrhagic complications. We can use Doppler. We have to check any pseudo reason, the pseudocyst before puncture. It is very important to appreciate the appearance of the aspirates to rule out the possibility of near-present before drainage. When we use ultrasound contracting, the case was referred for the possibility of drainage. Solid component was observed on the wall of the CT region. Subsequently, a contract US was performed, revealing a hyperenhancement of the solid component. EUS-FNA was continued to permit the diagnosis of the CT uterine tumor grade 2. This slide shows the state of the US-PC drainage. And the first is the linkage into puncture. Advanced skyway set she's through the needle, and the puncture needle is removed as well. The insert device for drug dilatation. The dilatation device was removed as well after drug dilatation. Then over the wire, a placement of stent. After survey with the more US, the first step of US guided drainage is puncture. Release distance of the wall-to-wall and avoid intervention vessel. And next, when maintaining the spherical position and observing the EUS image punctual with medication EUS FNA. Then aspiration for reanalysis. After aspiration, advance guide wires through the middle to the cyst with looping. For multiple stenting with body stent, 2 or 3 guide wires should be inserted to the CT cavity. We can use a rubber catheter or sensitized brush or a rotating wire. As shown on this video, following puncture with the medication needle, the first guide wire was inserted to the CT cavity through the middle. Subsequently, the second and the third guide wire advanced into the CT cavity by the rubber catheter. Before stenting, the trap dilatation is to be conducted. We can use a mechanical dilator, such as catheter dilator or dilator. We can also use the 6-branch quarterly dilators. Our setting of a generator for quarterly dilator for half lengths issues is shown on this slide. This video shows the trap dilatation was performed with the balloon dilator. After the trap dilatation, multiple participants was subsequently sent to the CT cavity. Usually 10-French double bacteria, less than 3 cm, 4 cm in length. Besides plasma double bacteria for drainage, our lamps can be used with a short procedure time and a large drainage aroma. Next, we need to discuss some relevant issues. What is the timing of the intervention? In AEG consent statement, tissue doses should be trained if they have a Hsiu-Po larger than 6 cm in size and causes symptom and complication. Although in this study, early and even acute EUS-guided drainage appears to be technically visible, clinically effective, and safe. However, most guidelines recommend an interval of more than 4 weeks for intervention. Another issue is stent. We can choose plastic stent or tubular metal stent or lens. There are several kinds of lens. The zero lens is from 10 mm ratios to 30-40 mm nano stent. Compare plastic stent with lens. Plastic stent and lens for the drainage of phagocytosis have a comparable success rate. A lens is associated with a higher risk of bleeding. Compare lens with the recovered metal stent. Lens have a shorter procedure time and a more adverse event. This slide summarizes the recommendations of guidelines on plastic stent and metal stent. When is the optimal time for the removal of stent following the treatment? Dr. Ben has suggested that lens will cause bleeding when the cavity collapses. In this retrospect study, delay of lens beyond 4 weeks was predicted by adverse events, including delay bleeding and very stent syndrome. This video shows a very stent. Where should the stent during cirrhosis be removed? The slide summarizes the guideline recommendation. For plastic stent, most guidelines recommend if TPTS exists, long-term plastic stent. Our lens should be removed within 4 weeks. But if TPTS exists, long-term PT is needed. If pigmental disruption exists, 2 options: additional transfibular pancreas stenting and the long-term persistent in ketrocytotomy. Pancreatic disruption can be divided into total and partial. Consensus by AEG recommended the insertion of pancreatic stent in patients with partially disrupted pancreas. In some studies, just popular pancreatic stent treatment, they bridge the disruption is associated with successful outcome. However, just popular pancreatic stenting in patients with total pancreatic disruption is not helpful. Ladies and gentlemen, by the end of my talk, I will promote AEG 2025 on 21st to 22nd June at Taipei. I'm chairman and my co-chair is Natalie. All of you are welcome. During the AEG 2025, we have very updated hands-on section, including HGS, CDS, covator drainage, pseudocyst drainage, co-embolization, GJ, RFA, and FNB. Thank you for your attention.
Okay, any questions from the participants before we move to the next session? I think Hsiu-Po has explained it very well in terms of the indications for procedure, some of the technical steps. Yeah. Any comments? Perfect talk. No
Okay.
question. No, but hang on.
Thank you.
So right now in practice, do we all use lens or do we still use plastic stents? Everybody uses lens. Despite studies showing that plastic stents and lens have similar efficacy, but maybe cheaper, everybody still uses lens. Okay, so Weta, why do you use lens and not plastic stent?
I think firstly is that I think one thing is that definitely pancreatic fluid collections are not common to come by. That's the first thing. The second thing, I think when we do intervene, the cyst size is actually quite large, and obviously LAMS does actually is much, I would say, comparable, even faster type of procedure time. Yeah. And then third thing, I think is something new here on the block, so everyone is obviously willing to try out. Yeah.
How about the cost perspective? Value, cost. but I guess value is different. I mean, we have to look at value to patient and all that, right? So maybe the cost may worth the value to patient.
Yeah.
Vinay?
Time is money. I use my I use most of the time.
Yeah.
I find that it's much more predictable as it reduces the need for instrument exchange. It's much faster. So I think that may be a little bit safer. But I get what's point about cost to patient. I think both are.
But I guess end of the day, we want to simplify procedures, right?
Yeah.
And because for us here, actually pseudocysts, there aren't that many cases, and as you pointed out, having to do exchange requires many steps, and sometimes it's something that you don't do too often. The coordination with the assistant and all that may not be ideal, and then we end up slipping on wire, and so. But I guess end of the day, it all depends on your preference. I think both are equally acceptable.
I think the because not every country is rich, like Singapore. Fortunately, Taiwan reimbursement will cover high issues and LAMS in this June. So I believe in Taiwan, no more plastic stent. But in some countries, maybe plastic stent is still have the choice. And of course, Today, our hands-on is practice there.
With lens also.
Also,
Yeah,
okay,
lens
okay.
hands-on.
So that's why I didn't demonstrate a lot of lamps, because in Taiwan we can experience a Nagi stand, we have Zeus IT, we have tubular stand, many kind of stand we have experience, but still have some issue to discuss, because in Singapore you only have a high shows.
And we
That's
have
right.
also
Zeus IT.
Zeus IT also.
Yeah, they have some. I think there are some other problem Korea lands.
Yeah.
Then maybe we can discuss about later. How issues maybe is a more confident lands for the drainage. This is my opinion.
Okay, thank you.
Yeah.
All right, thank you very much. I think we move on to our next speaker. Anthony, thank you very much for being part of our faculty.
Hello, thank you. Thanks for
Yeah,
inviting me.
thank you for taking time out, Nick. Yeah. So I think we are very privileged to have Prof. Anthony Teoh to talk to us about EUS guided gallbladder drainage. So quite apart from being a very excellent endoscopist, he also does excellent science. So we were talking about evidence-based medicine earlier, right? So he has a science and a technique, and he can combine both very well, because sometimes real life we have to do something not really aligned to science, but I think he has sort of mastered both, and he's going to share his experience to help us do something better. So all yours, Anthony.
Thank you very much for your kind introduction. I think we all work together to establish the science and support what we like to do. So I'm going to be talking about gallbladder drainage, achieving excellence. So these are my conflicts of interest. So when we talk about endoscopic methods of gallbladder drainage, it's really a logical progression from ERCP, where we drain the bile ducts. So with better techniques, we can also drain the gallbladder. And in terms of draining gallbladder, actually, we can do both a transpapillary kind of gallbladder drainage, similar to ERCP. We cannulate the bile duct and then pass a wire into the gallbladder and then insert a stent into the gallbladder. Of course, this is more technically demanding. Sometimes the cystic duct is obstructed by stones or strictures, and this may be difficult. Sometimes there may be some valves, and the tortuous cystic duct also causes difficulty in transpapillary drainage. And with transpapillary drainage, we can either do a nasal gallbladder drain, or we can insert a 7 French or double pigtail plastic stent. But with EUS, nowadays we can also perform a transmural gallbladder drainage in a very fast and efficient manner. And this can be done either a transduodenal route or a transgastric route. In terms of how transpapillary gallbladder drainage compares to EUS gallbladder drainage, I think there has been multiple comparisons published in GIE or other journals, and basically just confirming what I've said just now. In terms of success, the technical and clinical success is better with EUS drainage. With a larger size stent, also the risk of recurrent acute cholecystitis and also adverse events is lower. So if we focus on EUS gallbladder drainage, actually this has been described for quite a long time. So Todd actually did the first one and reported the first one in a patient with hypocholangiocarcinoma, subsequently developing acute cholecystitis. This was the very early stage. At that time, there were no accessories, so there were no EUS-specific accessories, so you can only use ERCP devices, and only a double pigtail stent was inserted. So at that time, people still think gallbladder drainage is quite risky because the gallbladder is in itself a non-adherent organ. It's quite mobile, so when you poke it, you puncture it, sometimes it can move away, and there's a risk of leakage. And also there is also a risk of stent migration, bowel leak, or even free perforation. And with the advent of, whoops, sorry. And with the advent of luminal pulsing stents, so we all know Ken very well. He is the first person who envisioned US guided gallbladder drainage, and actually the Axios was designed with the gallbladder drainage in mind. So the Axios initial drawing of the Axios shows two flange and opposes the two lumens together, and really reduces the chances of any risk of leakage. And I think Axios or the lamps has really revolutionized the scope of EUS. Also, a endoscopist controlled mechanism is very interesting. It allows a lot of precision to performing the procedure. Nowadays, we have a whole big family of lumen opposing stents, not just Axios, but also the Spexis as well as the plumber stent. I won't consider Nagi as a lumen opposing stent because the lumen opposing force is really quite low. But LAMS is characterized by the presence of high lumen opposing force. There are flanges on both sides of the stent to prevent migration, and also allows the passage of skull or large gallstones to move through the stents. Of course, sometimes a high lumen opposing force may cause a condition known as buried stent syndrome. Initial reports of Axios in the use of PFC has noted a higher chance of bleeding. And sometimes fluid particles can go through the stent intentionally or unintentionally. Up to now, we still don't know exactly how much lumen opposing force is needed. If you look at this diagram, we can see Axios has the highest lumen opposing force, around 3.5 newtons. And the plumber and Spexis is probably at around the similar level. But the other stents, tubular stents, are much lower lumen opposing force. So to put this into perspective, when you do a colonoscopy, if you push hard, it can be up to 6 to 8 newtons. So actually this force is not that high. So it also means that once you place the stent, you can dislodge it if you push too hard. Also, the advent of single-step devices has really changed the way US procedures are performed. So it has changed the need of a multi-step procedure into a single-step procedure. And some of my trainees have become so used to single-step device, they actually find it very difficult to do all these multi-step procedures. So I think US-specific devices are really important because it allows performance of novel procedures, reduces the difficulty of procedures, reduces the risk of leak, and more importantly, decreases the learning curve, makes the procedure easier for our trainees to learn. In terms of deployment systems, we are all very familiar with assistant control deployment systems, but with US LAMS, we also have endoscopist controlled systems. Do we need it? Of course, it's nice to have these endoscopist control system. In the past, only Axios is available, but now also the IT Zeus stent is also an endoscopist control system. And very soon, I think Taiwan will come up with one endoscopist control system as well. So do we need it? Is it essential? Of course, it allows precise control by the endoscopist. You don't really need a very experienced assistant, and already you can do the procedure. I think in small targets, very contracted gallbladder is useful. Of course, the main issue is cost. So if we can make a cheaper one, maybe more endoscopists will use it. Of course, you need to have some training and practice to use the system. So in terms of axios for gallbladder drainage, the first series was published by Itoi Sensei. 5-patient acute cholecystitis, technical success rate 100%. Afterwards, we also participated in this Galaxy study in 2016. 11 patients, transgastric, 19 transduodenal, a total of 30 patients. Technical success rate was 93%, major complications 7%. And I think in this study, we really sort of were exploring the technique of gallbladder drainage. At that time, we were still using the cold axios. We needed to puncture, put in the guide wire, burn with a cystotome, dilate with a balloon, and then insert the axial stent. I wasn't very familiar with the axios, so there were some misdeployments, but it was a very interesting learning period of time during the Galaxy study. Afterwards, the hot axios became available, and we published the first case report. This was a patient that had a percutaneous drain inserted, but the gallbladder was still inflamed, 90-plus-year-old lady, I think. And we did this case as a live demo. And then the hot axios burned into the gallbladder very nicely. And we deployed the stent as per usual. At that time, we were still practicing the way to deploy this is to observe the black mark, but nowadays I think no one does that. And then we deploy the stent. And in this patient, I think it worked very well because you can see the percutaneous drain there. It wasn't really useful because the pus was so thick and couldn't drain out the stomach or the gallbladder. And in this case, we dilated the stent. And then we went inside and washed a bit as well. So you can see the percutaneous drain in this patient. This was a important case report because one of the first reports of hot axios and cited more than 125 times. So nowadays, I think we all agree in patients with surgical candidates, lab chole is still the standard. In marginal candidates, lab chole is still the standard, but in very high risk of patients who are probably not surgical candidates, and according to our drag study, US gallbladder drainage should be considered. So the drag 1 trial, I think all of you have seen this. US was associated with less one-year adverse events, and particularly recurrent acute cholecystitis was much lower, 2.6% versus 20%. And then there were other benefits like less reintervention and unplanned admissions and 30-day adverse events. And thereafter, several societies has published the guidelines. This is from EUS-GB. In patients with high residual risk, US gallbladder drainage should be favored over percutaneous drainage due to lower rates of adverse events and need for reintervention. Strong recommendation, high quality of evidence. Similarly, AGA also proposed US gallbladder drainage in patients with high risk of cholecystectomy or in long-term percutaneous long-term PTC patients or patients with malignant biliary obstruction with failed ERCP or failed EUS-PD. And the contraindication, of course, is a gangrenous gallbladder or perforation of the gallbladder. The drag 2 trial is currently ongoing. This is led by Shannon. This is to compare US gallbladder drainage versus antibiotics first for mild to moderate acute cholecystitis. So patients in the past will be given a course of antibiotics. If they are not responding, then they would receive US gallbladder drainage. But in this study, we would want to see if performing gallbladder drainage earlier would be beneficial. So they were randomized to receive US GBD or antibiotics first, and the primary outcome is the rate of recurring acute cholecystitis. This is still ongoing. We only recruited 20% of patients, but the treatment success rate was already overwhelming, 90% over versus 36%, and significantly more reinterventions required in the antibiotics arm, 5/11. Hospital stays significantly shorter, time to resumption of diet significantly shorter. So, and then there's a trend to more recurrent biliary events in the antibiotics arm. So, suggesting maybe even in mild acute cholecystitis, we should drain the gallbladder with EUS guided methods earlier. So in terms of approaches to gallbladder drainage, I want to stress not all gallbladders are the same. There are two methods that you can perform drainage. One is the direct puncture, which we often use with acute cholecystitis, a very distended gallbladder. But in some patients, particularly those with PTC, they have a contracted small gallbladder. So in these cases, you may consider to use the conventional method, insert a needle guide wire, so that if something problematic happens to stent deployment, you still have the guide wire and you can do something. Devices used, 90-gauge needle, guide wire. If you are using a cold system, you would need a cystotome, balloon, stents. I prefer luminal pulsing stent. If not, you can also do the biliary SAMs, plastic stent. In general, it's not preferred. So this is a EUS gallbladder drainage with the ZUS system. The puncturing is similar to axials. We push the delivery system into the gallbladder. And then in this case, we insert a guide wire. We turn the knob 180 degrees around. We open the distal flange. We observe under EUS guidance. We pull back and then we open the proximal flange here in the channel, and then we push out the stent, and then the procedure is completed. You can see it under endoscopic images. So a previous discussion was whether we should drain through the duodenum or the stomach. In this study published in EIO, they had 68 patients. They found that the risk of recurrent cholecystitis was around 4%. Symptomatic LAMS related AEs were related to the gastric location of the stent compared to the duodenal location. So 66% versus 12%. So I think in the stomach, sometimes it is problematic because the stent can obstruct the pylorus, or more frequently is food substance can go inside the gallbladder. So in general, we prefer drainage through the duodenum. In the past, we often discuss whether we should do long-term stenting or we should remove the stones and remove the stent altogether. So in this study, we compared our data with Perez-Miranda's data. In the cholecystoscopy group, the recurrent biliary events was actually significantly higher, 37% versus 13%. Recurrent cholecystitis rate, 20% versus 5.6%. Recurrent cholangitis, 27% versus 5.6%. So actually doing less is better in this group of patients. So once we insert a stent, we should just place it there indefinitely. So this is the Kaplan-Meier curve. In terms of cost-effective analysis, comparing EUS-GBD versus percutaneous GBD, we found that although initially the average cost per patient is slightly higher, mainly due to the cost of stents, but the cost of reintervention, readmission is lower. But the total cost of gallbladder drainage is still higher, mainly due to the cost of stents. So this means that we need a cheaper stent, and perhaps the Asian counterparts, Korean stents, may be able to show a cost effectiveness with EUS gallbladder drainage. in terms of conversion of percutaneous gallbladder drainage, these are usually in patients with blocked cystic duct or a partially open cystic duct. When you do this, make sure you check the patency of the PTC, because sometimes it will be dislodged. And then if you don't have the percutaneous drain, you cannot distend the gallbladder, and then you cannot perform the EUS gallbladder drainage. If you dislodge it, if it's dislodged, you can consider to do a ERCP and put in a nasal gallbladder drain to distend the gallbladder, but this may not be easy. And the gallbladder is usually contracted, so it's a small target, and we need to distend with fluid or hyaluronic acid via the PTC. This is one such patient. You can see the gallbladder is small. There's a big stone there obscuring the lumen. And then here, I think I inserted a needle. You can see the cystic duct has partially reopened, but there's a big stone lodged there. So we insert a wire, and then we insert the delivery system. So the image is not great because it's small gallbladder. So the area for manipulation is small. So once the delivery system is inside, we open the distal flange and then the proximal flange in the duodenal lumen. Okay, so how are you doing for time? Till now? So
I think let's continue. I think we're doing all right. We're a bit over by 3. I think all these are important tips for us.
So just a few cases of troubleshooting. This is a very early on, 4th case, distal flange in the gallbladder. Stent insert the gallbladder after dilatation, distal flange deployed, but proximal flange deployed after visualizing the black mark. However, the stent was deployed in the gallbladder. Another axial stent inserted, stent on stent, uneven recovery. So this was a misdeployed stent. So yeah, first part, very gone very well. Distal flange opened, and then we pull back the stent, and then here we were still visualizing the black mark. Okay, let's go back a little bit. Okay, so here is the black mark. And then I deployed the proximal flange. And then nothing happened. So does anyone know what happened here? I can see this blue thing. Can anyone tell me what happened here? So actually, when we deploy the proximal flange, you need to remember you need to lock the second button. So the on the deployment system, so if you push the stent in, you have to unlock the first part first, and then push the delivery system, and then you lock it, and then you open the distal flange, and then you unlock the delivery system, and then pull back the stent. But you need to remember you need to lock the delivery system before you open the proximal flange, because if you don't lock the delivery system, without locking it, it becomes a forward deploying stent. So once you push the proximal flange, it actually deploys forward. So the stent will be pushed into the gallbladder. Okay, a moment, I need to take this call. Wait. Okay, 5 minutes. Bye-bye. So this whole stent was actually pushed into the gallbladder. Okay. So this was a misdeployed stent. See, right there. This whole stent deployed into the gallbladder. Okay. So if this happens, it's not a big issue. Make sure you have a wire in situ, and then you can do a stent on stent if you have a wire in situ. In this case, we We had another axials on hand, so we deployed the distal flange in the first axials, and then we deployed the proximal flange, so stand on stand, so the patient was fine. So this is what it looks like, 2 stents. And the CT showed no leakage. Draining through the stomach. So sometimes it can be very close to the pylorus. So sometimes, usually I prefer to drain through the duodenum, but in some situations there's no window and you can only see the gallbladder from the stomach. So if you do so, make sure you're not so close to the pylorus because the lamps can obstruct the pylorus. And also, stenting through the stomach would sometimes result in the buried stent syndrome. So the buried stent syndrome is because the stomach would tend to move away from the gallbladder. So day 0, day 11, you can see the stent partially migrating out, and by day 17, there's still an opening, but it's almost completely out of the stomach. And food can get inside the gallbladder if we place it too close to the sorry. So this is some food in the gallbladder. So in this patient, actually, she had recurrent cholecystitis due to this. So at the end, we have to remove the stent and overstitch the opening. Okay, so in conclusion, EUS gallbladder drainage for acute cholecystitis is advantageous. Technique is becoming standardized, and attention to details is important for good clinical outcome. So thank you for it.
Thank you for your excellent presentation. Any questions from the audience?
What size does he use?
What size do you use for your lamps for gallbladder drainage?
Okay, so it depends on the size of a stone. So if the stone is less than 1 centimeter, you can still use a 1 centimeter stand. If it's bigger than 1 centimeter, you may want to use a 15 millimeter stand. If the stone is very big, you may also consider adding a plastic pigtail to avoid the stone from obstructing the lumen of the stent.
I guess related to that question would be, you were saying for contracted gallbladder, you use the multi-step approach, right? And so does that mean you also use a smaller stent?
Yeah, usually 1 centimeter,
right?
yeah.
You know, interestingly, we were just discussing earlier during our Hsiu-Po's presentation on pseudocyst drainage. Here, I think everybody used lamps and hot axials and so on, using a one-step approach because I think people have sort of forgotten how to do multi-step approach. So I saw then if they want to embark on gallbladder drainage, then they probably have to have some familiarity with the multi-step approach. And which means to say that maybe more ideally they should also be doing ERCP, right? And therefore use to all these exchanges and so on.
Of course. But I think nowadays most people are doing EUS and ERCP. Very few are just doing EUS alone.
Any other questions from the audience? You know, earlier on, okay, I'll ask questions just to stimulate the thought process. So if you all have questions, please stop me and then I'll stop talking and you can ask Anthony. All right, so you're sharing that when you first started a few cases, you were sharing that maybe you're less familiar then, so there was some issue, and then you did more, then you get increasingly familiar and so on. So, you know, all these procedures, we don't do that many. And I just wonder about the issue of credentialing for therapeutic EUS, you know. It looks like quite tricky, and we don't all to not be able to do things because we don't have enough number to show and all that. But on the other hand, so I just want your thoughts. You know, if let's say someone has started doing FNA, does ERCP, you know, in current climate, right? Current state, can the person just, you know, slowly do, and we don't bother too much about how many they have done before they can embark on all this drainage procedure?
Yeah. So I think, of course, we have published a lot on this, and then for PFC, the magic number is some studies say up to 20, 30. In our own guideline, we suggested that if you are familiar with FNA, done more than 250, you can do a PFC drainage under supervision, maybe 5 to 10 cases. But of course, I think the most important thing is try to have someone who is experienced with you, and I think nowadays it's easier because it's a lot more familiar. A lot more people are doing this, and start with something more simple like PFC. Gallbladder is actually a good target as well because usually quite big in acute cholecystitis. And then for CDS as well, the target is usually easier. And then once you are familiar with all the devices, then go step by step. And of course, practicing in models is important as well.
I'm just wondering from a regulatory perspective, should we have some clear, obviously learning curve, the more you do, the better you are, right? I'm just wondering from perspective of regulation, do we want to say how many you do before you can do this, or so long as the person is credentialed officially in EUS FNA, does ERCP, and maybe do one or a few pseudocyst drainage under guidance, then the rest you just leave unmentioned and let the individual do based on their comfort level. Because it's a balancing safety, balancing practicality and feasibility in the real life.
Yeah. I think so far there's no society guideline on what's the required number, but
yeah, I think
we
we
agree. So you need to balance. So, but I think the number is around 20, 30 cases of intervention in the US.
Yeah, we probably want to stay silent officially. Otherwise, no one here can do anything and they'll run in trouble. Okay, finally, we have someone from the audience asking question. Martin? Press a bit more. Make it, yes, be green. Just
Hello. Hi, Prof. Teoh, thanks for the excellent presentation. My name is Martin from Sengkang Hospital. Can I just ask, in your experience, because these are high-risk patients, do you do these procedures under sedation versus anesthesia? Can you share your experience?
Yeah, I think actually all our cases are under sedation. So because they're emergency cases, of course, if you are just starting the procedure, you may feel more comfortable with MAC, but it's not essential for gallbladder. And actually, most of the time is finished very quickly, 5-10 minutes. So,
yeah.
Thank you.
Okay, thanks. That's probably faster than the time for the anesthetist to get things ready. Yeah. Okay, so I think no more questions. So then, Anthony, thanks a lot for
thank you so much
coming in. Yeah, thanks a lot. Hope to see you soon in person, maybe in June. See you.
Okay, bye-bye.
Bye. Okay, so it's hi Vinay. Nice to see you again. It's been quite a while. How are you doing?
I'm good, thank you. Thank you for having me.
Yeah, thank you so much for taking time from your busy schedule to share your experience with us. Because my idea behind this course was to help make the learning curve for the younger practitioner less steep, and so that they can spend less time mastering what we took a longer time to learn. And I think it's important that they learn from the true masters, and that's why we hope that you can actually share your insights on therapeutic EUS. So you have been asked to talk about EUS guided CDS and HES. So yeah, so please start. Thank you very much.
Thanks, Ting Leong. Thanks, AEG. It's a fantastic course. Can you see my slides?
Yes, we can see your slides.
Okay. So, yeah. Any issues? It's all okay? Should I start?
Yes, it's okay now. We can see.
Okay, fine. So let's talk about CDS and HGS. CDS, as we all know, is placing a stent between the duodenum and the bile duct, and HGS is placing a stent between the stomach and the left intrahepatic biliary radical. Obviously, the indication would be malignant obstructive jaundice. So this is a general slide, good for all procedures that we are discussing today. You want to have a good outcome. Procedure itself is one important essential, but you also need to choose your patients wisely. So the patient has to be appropriate. The procedure has to be done in the proper manner. You should have good scopes and good accessories, and also you should have possibilities of surgery or PTBD in the event of failure. So it has to be set up where everything is available. And then finally comes the question that is the topic of the talk today, the expertise or excellence, if you want to call it. But it's a composite of multiple things that decides a good outcome. So choose an appropriate patient, a patient who is very sick, has multiple liver metastasis, is not expected to live more than a month or two, probably is not the right patient. Patient who has massive ascites, please see if patient's general condition is good. You can drain the ascites and then do both these procedures, because it's not an absolute contraindication, ascites, but it gives you an idea of a very advanced disease. So choose the patient wisely. Has the patient undergone a prior surgery? Is there a hepatico-jejunostomy, or is there any gastric bypass? So because that will alter the procedure that you are going to do. And of course, is the patient on antiplatelets or anticoagulants, because we will be using cautery and that can cause bleeding. And finally, explain the success rates and the adverse events of the procedure to the patients and take an informed consent before we do the procedure. What about the procedure? So there are, as you know, lots of procedures for a distal biliary obstruction, malignant biliary obstruction. You can do HGS, you can do CDS, you can do gallbladder drainage, and there is no guideline as to what is an appropriate procedure. So this is the algorithm that we follow at our institute, and this is based on the data that we have published and which we are going to publish. So any malignant biliary obstruction, our first recourse is ERCP. So ERCP is the first choice. And if it fails, then only we consider EUS guided biliary drainage. Amongst the EUS guided biliary drainage techniques, antegrade procedure is our first choice. We like transpapillary drainage, and we have data to show that transpapillary drainage is superior to the CDS and HGS. If antegrade fails, or if at your center expertise for antegrade is not available, then decide what you want to do based on the type of block. So for a hilar block, obviously you will not be doing CDS. So you do HGS. And for a distal block, you have a choice of doing CDS and HGS. Increasingly, there is a data that if you have duodenal stenosis, probably CDS may not work as well. So HGS is becoming a preferred option. So if you want to learn two procedures that will help you in almost all cases, it's antegrade procedure and hepaticogastrostomy. So developing expertise is a long process. It doesn't develop overnight, as you know, And what we are worried about when we are doing these procedures is the adverse events. Now, adverse events, this is a general slide for EUS guided interventions. It applies to CDS and HGS also. The adverse event rates are initially, when you start the procedures, high, and they can be morbid and they can be fatal also. So you have to be ready for that. As you do more and more procedures, you will see that your intervention, the adverse event rates are coming down, and you can bring it down to single digits with expertise. You have to be aware that some adverse events will prolong hospital stay and could also be fatal. So you have perforations, bleeds, infections, and mal-deployed stents. All of this can happen with CDS as well as HGS. So serious adverse events is a problem, and part of our expertise, a large part, is understanding these adverse events, anticipating adverse events, trying to avoid these adverse events. So that is expertise when your adverse events come down to single digits. So how do you do that? You understand the finer points about the technique and anticipate adverse events. That's very, very important. If you have an adverse event, anticipate and act quickly. Once the adverse event is known, don't wait, because then the fatality rates will rise. So these are, you can see this is an HGS. This is a very old slide when smaller HGS stents were used. You see here, this stent has slipped away from the stomach into the peritoneum. So this is what we have learned about HGS over the past decade, to use longer stents, to use partially covered stents, so that these things do not happen and peritonitis can be avoided. So this is part of expertise and learning. What about technique? So as you know, both CDS and HGS will require needle puncture, wire passage, tract dilation, and stent placement. These 4 things are required. For LAMS, of course, the technique is different. But by and large, if you're using a tubular stent, then these are the 4 steps. And for you to be successful, in my opinion, and there's no data about this, scope position is extremely important. It's just like ERCP. If you have a good scope position, you will succeed more often. If you do not have this good scope position, you will start having problems very soon. So have a good scope position, and then throughout the procedure, maintain that position. That is a very, very critical point. Your scope should not move from. And how do you know that your scope is not moving? Keep looking at the ultrasound picture, and your wire should be seen on the ultrasound. As long as you are seeing the wire on the ultrasound, you are in a good scope position, and you are maintaining the position which you decided was okay to begin with. So multiple scope positions for multiple procedures. You want to puncture segment 2, it's a different position. Segment 3 is a different position. CDS, you see, it's a different long scope position or a semi-long position. And rendezvous, they're different positions. So you will have to learn and master getting a good scope position before you make your needle puncture. So if you are going from the duodenum for CDS, multiple scope positions can be there: semi-long, long, and short position. So when you are doing a short position, it's not obviously good for CDS, because you have to go towards the hilum. With short position, you are looking towards the papilla. It's good for rendezvous. So avoid short position. Long position is ideal, where you are looking towards the hilum. So look on fluoro before you puncture, how is your scope position? If it is looking up towards the hilum, you are good. Very often you will get this intermediate position where it is not really looking up or down. Here also you can do CDS, not a problem, but it may be little tricky because the accessories will come at right angle to the opposite bile duct wall. So you have to be careful about that. So scope position in the duodenum, similarly scope position in the stomach. So segment 2, if you are doing an HGS, it can be done from segment 2 as long as you are sure that your scope is below the diaphragm. So check on fluoro before you puncture a segment 2 where you are exactly, because we do not want the HGS stent exiting in the esophagus. So before you puncture, do a quick fluoro. So for that, we keep the patient flat generally in our unit, but it can be done in left lateral also, not a problem, or semi-prone. So look, so for segment 2, you will see a scope like this, something like a straight scope almost at the level of diaphragm. So be sure before you puncture that you are below the diaphragm. For segment 3, again, multiple positions can be acquired. What is important is A, your scope tip is looking towards the hilum. It should not look the other way because then the wire will go towards the periphery of the liver. And B, you have a good angle to pass the wire. So if you have this angle, for example, it is a good angle to pass the wire. Not very important in HGS, wire passage, more important in antegrade, but still you need to take it till the hilum and coil it there. And if you are very much below, then you have acute angles and you may find it difficult to reach the hilum. So learn to do good scope positions, both in the stomach and in the duodenum. If you do not have a good scope position, for example, if your scope is away from the stomach wall while you are deploying the stent, the potential space between the stomach and the liver or the duodenum and the bile duct opens up, and part of your stent will open up in that potential space. This is called as Candy sign. You can easily recognize it on fluoroscopy. Per se, it will not cause a problem, but it increases the chances of stent migration. So whenever we see a Candy sign, we try to place another stent through this stent. So this has to be avoided, and the only way to avoid it is have a good scope position. See, this is a Candy sign while you are doing a hepaticogastrostomy. The space between the liver and the stomach, the stent has opened up here. These things have to be avoided, and you have to keep the scope very close to the stomach wall at all times. So if you are going on seeing a wire on the ultrasound, you're also seeing that your scope is flush with the stomach or duodenal wall and not away from it. Then these problems can be easily avoided. So simple tips which can prevent these problems. So this is a Candy sign. See, the scope is very far away from the bile duct, and so you have this part of the stent deployed between the duodenum and the bile duct. So this has to be avoided. Another problem which can happen if you are keeping the scope a little away from the gastric wall is when you're pushing the accessories, a wire or a dilator, sometimes because you are pushing it over an angle, see this is a 90-degree angle, there will be a resistance. And when there is resistance, your scope tends to go back, and you have to be aware of this fact. So when the scope goes back, the accessories can form an angle like this. See this happened to us once. If you recognize it early, it can be easily corrected, but the best way is keep the scope in a tight position always. Wire manipulation, not so important for CDS and HGS, more important for antegrade and rendezvous, but still you need to keep the wire in a good position. We use a Terimo wire but Visiglide, 025 Visiglide is also very good. If you are using a Visiglide, see to it that the soft part of the Visiglide is quite deep, because you do not want to push your stent over the soft part of the Visiglide. So the hard part of the Visiglide should be there, enough of that should be there for you to push the stent nicely. Otherwise, the stent may coil and cause problems. A good GIA is a rarity. So I would say if you have a good GIA, you are a very lucky person. If you don't have, then learn these techniques yourself, and then it will be easier for you. One of the problems, again, is not a serious problem, but it prolongs the procedure. Guide wire shearing can happen while you're passing the wire. So the needle tip is usually very sharp. And if you're making rapid movements in and out, then the guide wire can shear. Once the guide wire shears, it stops moving properly. And then probably you'll have to remove the whole thing and make a fresh puncture. Avoiding that is pretty easy. Your movements have to be slow when you're pushing in the guide wire or pulling it back, and deliberate slow movements, not lot of guide wire at one place. Because if you put lot of guide wire, like sometimes we do in ERCP, and then it has not gone in the right place and you want to withdraw it, it'll shear. So if you are getting resistance, then you have to withdraw it very slowly. If it is still not coming, remove the needle from the scope hub a little bit. It straightens the axis, and then slowly withdraw the wire. So all these things can be prevented. Shearing, you can see this, there is shearing here. It prolongs the procedure. The next step is tract dilation. So wide variety of dilators are available. My Japanese friends actually have a huge number of dilators available to them, primarily because they don't like the cautery dilator, the dithermy device. Avoid using a pre-cut papillotome because it's not coaxial. So use a 6 French cystotome, our favorite device. We don't use anything else. So at our center, it is a 6 French cystotome for dilation, but a bougie dilator or a balloon dilator is also okay. So you can see you have a variety of dilators. Hurricane is commonly available, Boston Scientific, but you have some Japanese dilators also not available in India. So we only have Hurricane here. So tract dilation is the next step. And then finally, placing the stent. So which stents are good for CDS and HGS? So for a large CBD, if you are doing a CDS, lamps is an option and a covered metal stent is an option. Don't use uncovered metal stents. We have used plastic stents in occasional patients because of cost issues, but we do not recommend its routine use. What about CBD diameter smaller? If you are expert, you can use a lamps, otherwise avoid lamps because you can have problem in deployment. A covered metal, of course, can be used. So these are the two stents which we use for CDS. For HES, you can use a plastic stent if there is a benign indication. There is a special stent made by Professor Itoi, the IT stent, again, not widely available. Or you can use an uncovered, partially covered stent. Don't use an uncovered stent, it will cause leak. Some friends in US use a fully covered stent also. There is a fear that it will block the side branches in the liver and can cause atrophy later on if the patient lives long. So we use a partially covered stent, 70-30 cover or an 80-20 cover. Why is the cover important? The cover is important because it should traverse the liver and the space between liver and stomach so that bile leaks can be prevented. So use a partially covered stent for HGS. Stent deployment is important. It is different from ERCP. In ERCP, we usually push the stent fully in, while here we tend to deploy the stent within the scope and push it out so that it is more controlled and it doesn't suddenly go inside the bile duct completely. So deploy it within the scope and then push it out slowly by changing the angle of the scope. So I showed you this. This is because a smaller stent is used. So don't use a small stent for HGS. Use a longer stent. If you have 5 centimeters of stent within the stomach, there is no problem. At least 3 centimeters should be within the stomach. So use a long, partially covered stent. So this is how an HGS stent should be deployed. See here, we are doing it. The stent is actually, see here, we are carefully deploying it. It's a long stent still coming in the stomach, almost 4 or 5 centimeters. And then you withdraw the wire. If you want, you can place a plastic stent, but this is essential. Use a long, partially covered stent, deploy it fully under vision. If you are keeping the wire very tight, then sometimes the stent will get completely pushed within the biliary system. So keep the wire loose, don't keep it very tight, and slowly withdraw under vision. Coming to LAMS, LAMS is a great stent for GJ, for pseudocyst and gallbladder. I personally do not consider LAMS to be a great stent for CDS. I know there are 2 randomized trials published in gastroenterology, and it is a very easy stent to place. It has a great delivery device. You do not need much assistance, but the stent is primarily not designed for placement in the bile duct, and I will show you why I say that. There are adverse events, not too much, moderate adverse events, same bleeding, perforation, mal-deployment. And what we want to avoid as endoscopists is the unplanned procedure events. So the stent suddenly gets deployed completely within the bile duct or is deployed within the duodenal wall. So you can have deployment failure and misdeployment. These are the things which we can avoid, and that is again part of gaining expertise, experience. So this is what happens. The stent is very easy to place. So if you place the first 2-3 stents, you will feel it's great. It's so easy. And you feel very confident. And then suddenly you start having problems and you don't understand what is happening. So this is called as Dunning-Kruger effect. After you have done a few stents, you realize what is the technical problem, what should be avoided, and then you get great results without much problem. So I will just show you a video here of the CDS. I prefer tubular stents, as I told you. So this is the place where we usually puncture. This is a case which had duodenal stenosis. So you see here, so there is a stenosis here at the level of D2, D3. So ERCP is not possible. So we did GJ and a CDS. So EUS, see where the puncture is done. This is usually in D1 or a D1, D2 junction. Mostly it will be in D1. So choose that side, put your ultrasound, see a dilated bile duct, use Doppler, see that there are no major vessels between, and then do a fluoro to see the scope position. So this is ideal scope position. Scope is looking up towards the hilum. Then puncture with a 19 gauge needle, aspirate bile, and then pass the wire. So because this position is so good, you will find the procedure is not too difficult. But my biggest problem with CDS is this segment. You see here, this segment usually doesn't drain when you do either with tubular stents or with lamps, because there's a long segment. We want to avoid the cystic duct, so we usually puncture above the cystic duct. So the lower part of the bile duct, the bile flow is not good. You must be knowing about the sump syndrome. So that is why CDS sometimes the stents get blocked pretty early. Here you have a cystotome and a wire. So if the scope is stable, all these things become pretty easy. So you have passed the cystotome into the liver, and now position the guide wire nicely before you place a stent. See here, so the soft part is quite deep now. We have this much length of guide wire to place our stent, and this position of the scope should not change. That is the main job of the endoscopist. Keep it like that throughout the procedure. We are using a fully covered stent, deploying it. You see the the second mark is still not seen because it is in the scope. So we slowly deploy, and then once we reach the bile duct, lower part of bile duct where we punctured, we shift to the endoscopy view and slowly, deploy the stent in the scope and push it out. So this is pushed out and you have a nice drainage. So pretty simple procedure, not very complex. If you are doing with a LAMS, I suggest you use a smaller LAMS. Don't use the 15 mm LAM. 8 millimeter is sufficient. And put a wire through the LAMS. That will improve the axis. So now I show you what I was telling you about the LAMS. This is from a friend. So this is a dilated bile duct. For some, it is probably not enough dilated. Puncture with a hot axios. You are passing a wire now. You see the axis, the bile duct is like this. And so the wire is going into see, this is a cystic duct. And your wire is entering into the cystic duct. So you do not have much space for the LAMS here. And you're trying to puncture, and it is not completely, see, very small amount of LAMS is in the duodenum now. And when you deploy it, there will be problems. So these things can be predicted. At the same time, you see a lot of bile is leaking here. So this is a problem already created because the bile duct is probably not adequately dilated and the wire is not in a nice position. Also, the LAMS deploys 90 degrees to the axis. It doesn't usually go up. So wire is good, but sometimes it doesn't work. So then once you have this problem, you try to place a tubular stent through this. It is not going to be easy because the LAMS has not fully opened within, and you will have problems. So these are some of the issues which you have to learn, anticipate, have enough length of bile duct before you deploy this LAMS. So if you have 15 millimeter, 13 millimeter, 14 millimeter, good. And then have a wire so that it deploys in the axis of the bile duct, not perpendicular to the bile duct. So these are some of the things with LAMS you will have to remember. Okay, so now, see, this bile duct is another case, is beautiful. You should be able to place a LAMS in this, but see what happens. So you puncture, hot cautery is employed, wire is passed, everything good, but see, a very small length of stent is in the bile duct. You have to push it more, but you have deployed it before pushing. So again, the same problem of space. Push the stent quite deep before you deploy it. Now here, the distal flange is deployed within the wall of the duodenum. So what you have to do is now catch it again. There is a technique, catch it again, and then you can redeploy. That's not a problem. But these are easily preventable problems. So ultimately, what is the essence is do more cases, do few under supervision, and then do more cases. So choledochoduodenostomy, proficiency at 32 cases. Now, it's not easy to get 32 cases, but this is where you get proficient and master 100 cases. Hepaticogastrostomy, 33 cases to stabilize 93% success. So at least 30 cases you have to do before your adverse event rates are falling to single digits. So it's a long process. Be persistent, don't give up. Everybody has adverse events. As long as we understand why it was created and don't repeat the same mistake the second time, it is okay. Thank you very much.
Thanks a lot, Vinay. You gave us a lot of very important practical insights. And I think these are the details that actually make our procedure either successful or it causes us hair loss. But anyway, thanks a lot. So maybe we have some questions from the audience. Anyone? It's not easy that we can have Vinay in front of us to ask him all kinds of questions. So let's make use of this opportunity. Okay.
Thanks for the excellent talk. I'm just wondering that some people actually recommend for like segment 2 HGS, you put a clip first at a GJ junction to avoid, poking.
Yeah.
Proximal. Do you?
No, Hara does that. He applies a clip. I don't think it is really necessary. A simple fluoro is good enough. If your patient is flat on the back, you have a fairly good idea. And also before puncture, you look at the ultrasound, you will see stomach, esophagus and stomach looks different, and on fluoro. So I don't usually place a clip, but I know some Japanese friends place a clip there so that you are sure that you are not in the esophagus.
Okay, Jun Yang is asking a question.
Prof, hi, JL Singapore. Can I just ask you your experience with tubular stents and CDS? I think you said that you prefer to use CDS stents, but I think in my limited experience when I use a tubular stent for CDS, I think on more than one occasion, after a few months, the tubular stent dislodges. So I'm just wondering what's the experience with your experience?
So, yeah, we have placed a lot of tubular stents. As I told you, I don't like lamps primarily because it is expensive in India. And number two, placement is not possible in about 30 to 35% of my cases because the CBD is not dilated enough for you to feel safe about placing a lens. So tubular, that problem is not there. You can place a tubular stent. We have finished a large randomized study, multi-center randomized study. The idea was to compare antegrade with CDS and HGS. The technical success rate of CDS is about 95%, very high success rate. Adverse event rates are not much. The problem we found was in long-term, stent patency. So antegrade had significantly higher, contrary to popular opinion. We all believe that since CDS and HGS do not go through the tumor, they should last longer. But as I explained to you in the video, there are segments of biliary system which are not drained well by CDS, the one below the puncture. And if we are placing a covered stent, and suppose it has gone to the left side, the right side also will not drain so well. So at about 2.5 months, you will start having stent blocks. So with antegrade, because it is like a transpapillary stent, it drains the entire system. And there we have found that the stent patency is longer, although technical success, because it's a complicated procedure, is lower, not significantly, but lower compared to CDS and HGS. And of course, you need a very good GI assistant. So there are problems with incorporating antegrade in your practice. CDS and HGS are much easier to incorporate. Their technical success, very high. Adverse event rates come down after a few procedures. So very good procedures. The only issue I see is stent patency.
And do you observe migration for your stent?
Yes.
You
Yes.
do, right? Because
Yes.
the diameter just expand and become loose and just.
Yes. That is why I said our first procedure of first choice is always ERCP.
Yeah.
So these are only for failed ERCPs.
Yeah. And I guess these are ideal if the expected lifespan is not so long. More for
Yes.
Okay,
Yes.
Hsiu-Po has a question. Just press the button. Is it green? You press below.
Hello, I'm Hsiu-Po.
Hi, Hsiu-Po.
I have two questions for you.
Yeah.
First is if you use high shoes for CDS, do you put the plastic stent, coaxial plastic stent? And the second question is for CDS, how about the diameter of the tubular stent? Because now there is small diameter tubular stent. For example, like a DUS 6 millimeter or 8 millimeter. So could you prefer the larger diameter or small diameter for CDS?
Fantastic. Both questions are great. So placing a plastic stent through either a LAMS or a tubular stent is primarily to increase the stent patency and probably avoid migration. It sounds logical, but the data that we have seen, there is a bumpy trial, which is a multi-center Spanish trial published in abstract form for LAMS, and it's a very interesting trial in a patients where the LAMS were placed alone. At 6 months, 35% of their LAMS got blocked. So this is in direct rejection of the two randomized trials that are published in gastroenterology. When they placed a plastic stent through the LAMS, their stent patency or stent block rate reduced from 30% to 9%. Significant, very, very significant. It has not yet been published in full form. So there probably is some data to place. Personally, I do not yet place a plastic stent through a tubular or but attractive idea. I think we will need more data before we can definitely say that it works. The second question is very, very good. Great question. Why not place a 6 millimeter stent instead of a 10 millimeter stent? It's very logical. You do not really need a 10 millimeter stent. There is one trial very long back. It has come for ERCP. I think it came somewhere in 2013 or 14, where they have compared a 10 millimeter SEMS with a 6 millimeter SEMS. It was for ERCP, not for EUS. And they saw a lot of stent blocks with the 6 millimeter stents. Now, whether that applies to EUS, we don't know. I love the idea of a smaller stent because it will be easier to place also. But probably we need to do some pilot studies and see whether it really... So placement will be easier, technical success will be higher, adverse events will be lower. But what about stent patency? Whether that remains as good as a 10 millimeter stent, we need to know that.
Thank you.
For maybe last question, for CDS, is it a tubular stent? Is there a minimum length that is ideal? Obviously, I guess it can't be too short, right? Then the shape, it doesn't, yeah.
Yes. So 4 and 6 are the two stents that can be used without a problem. But because it tends to migrate a bit always, I think a 6 one is a better stent rather than a 4 centimeter.
So I guess I can use a 6 or maybe longer stent like 8 cm. Would that be better than 6?
You have to be careful that you do not take the turn towards the right or the left, because then the opposite side will not drain well. These are fully covered stents. So it creates, a sort of a conduit.
Okay.
anything on the side will not drain.
Yeah.
So that is a problem I have with CDS, the procedure, not the stent. That there are areas, segments of biliary system which do not drain so well compared to ERCP.
Okay, yeah, I think these are very important insights that we can only learn after I've done several hundred cases. But and it's great that we actually hear all this from you, and therefore we can avoid all the mistakes. And I think that's why all these discussions are very, very important. Yeah. So, and I guess, yeah, we should still try to do ERCP and not really consider primary EUS BD.
No,
Like what some
I'm quite
people
yeah.
advocate. Yeah.
I changed my ideas.
Yeah, because as we do more, we conceptually certain things sounds great, right? But then we realize that actually potential pitfall that we never realize. Yeah. So, Chris, you have a question, or we?
Yeah. Hi, Vinay. It's Chris. Can I just
Hi,
ask?
Chris.
Hi, Vinay. Thanks. Terrific talk. So many practical points. I wanted to ask you about, CDS with the multiple exchanges that are needed. How do you avoid the problem of your bile duct deflating while you're swapping out things? The 6 French cystotome for the stent delivery system. That's when you have that biggish hole in your bile duct. Is it just a matter of doing it very quickly, or is there a special trick?
So again, I think it's a matter of time, of course, as you said, is important. But once you have dilated with the 6 French cystotome, it's not a very big dilator. So we do not dilate too much.
Right.
And then quickly place a stent. We haven't encountered a significant amount of bile leaking out. That doesn't happen. Probably because we have used cautery, that area becomes sealed off or gets coagulated. I don't know about that because we do not use non-diathermy dilators, and probably if we use that, the bile leak will be higher. Here, I don't know why the leak is not there, but probably I believe is the diathermy. So the bile duct wall and the duodenal wall, probably there is some kind of coagulation effect, and we rarely see a significant bile leak there.
Okay, so I think we have one more question from Wita.
Hello, Vinay. I'm Weita from Singapore. Excellent talk.
Hi.
I want to ask regarding EUS-HGS. If you have access regarding tract dilatation, if you have access to both mechanical and cautery, would you prefer one over another? Because in Singapore, generally, we only have cystotome available. So just thinking what's your thoughts on this?
So as I said in my talk, I love cautery. The cystotome makes the job so easy. It is very fast. There were fears initially that it will cause more bleeding because you are cauterizing a segment of the liver and of course the stomach wall. But we haven't seen significant bleeding, and this is corroborated by other studies also. So we do not dilate with a bigger because you have the 10 French cystotome also available. We don't use that. But a 6 French cystotome, in my opinion, is the best dilator. If you have those special Japanese dilators, which are very tough, they are very good. Then, of course, you can avoid cautery if you want to, but I see no reason to avoid cautery in my experience.
Okay,
thank you.
So, thank you very much, Vinay. And I think we are running short of time. So we hope to see you again in person soon and learn from you and so catch up.
Sure.
Thank you. Bye-bye.
Thank you.
All right, so right now we will have a 1 hour lunch break and we resume at about 1:30. And then Jonathan will talk to us about EUS-GJ before we do the hands-on. So lunch is provided just outside the door. So we'll
So I will put a cover in this.
Yeah, okay. So we resume again in an hour's time back here. So later on after Jonathan's lecture, Andrew will sort of distribute the participants for hands-on.
Any slides for participant and their practical stations?
You need this one?
Okay. Yeah, later we can flash this.
We'll show it in 1:30 after we come back from lunch.
After the lecture, one more lecture.
Oh yeah, one more after lecture. Yeah.
All 8 are here.
Giving a talk, is it?
Given, yeah.
Oh, given.
After the last session briefing.
Oh yeah.
Oh, you good? Good. Time to see. Yeah. I think the last time was empty. I remember it was last year. Yeah.
What keeps you busy now?
Oh, we focus quite a lot on these two emerging countries, Philippines and Malaysia. So, traffic population issue is population. So, when I go more activities now, the number of visitors in the country. Training issues, and we also now we have more toys, more simulators. So we try to use common model and also different kind of models to enhance the relevance. So the traditional one of the bring faculty.
They can't see anything, right? Then just pray for the best that it goes through. I realized the upside我一直在这个，因为他们那市场太小了，说，对，日本都会进台湾下一条，对，是因为他，可能是因为刚好他们在这边，他公司啊，有代理商，因为他是做比较多血管的东西，说，可能这边有输液脉的，因为之前我们用实时做有点怕了，但是老实说，导致部是超多他喜欢用。因为他没看过北美的，今天讲不同的地方，有一些地方它就是做某些事情，各种上面西方啊，现在只有东北亚、韩国、台湾、日本都有不喜欢员工的，美国、东南亚。欧洲的话好像都有啊，美国的话都是空的，对，他们没有，所以并不是说哪个东西比较好啦，他们都可以拿到。对，有些时候担心要留学的部分蛮 scary 的。你们如果有人入进来，可能就用，而且他们的EUS以后，现在很多人就开始弄嘛，很难填嘛。所以不是最厉害在 种打一个就前面就是尖的。
它那个前面很尖的，很尖，它其实最尖，它并没有那个 helical 是它那个前面那个头是那个心肝线，是那个头很长，然后它那个很长，所以你很太需求，它可以进去很多，慢慢进去。像你那个 helical 就 helical 是比较软的，还弯的很好，但是很硬的 helical 必须得比较少。那开垦又粗一点，但是开垦还是后面比较开垦的。
这进来就比较好一点。
对，而且做 EUS 也好，它可以直接跑出，然后它可以我们建议用 CDS 的，不要用来，都是你在那边因为你胃来了以后，它的拉手很强，对，它会回来。
老实说，我们做过的 CDS 都是用 F， 我们就是用。
那你们应该可以跟他们要不要再放？因为我们中间放好，过一阵子以后，它就因为它变小。
我也没有做太多力了，我做 HGS 比较多一点，经验方面。但我们就觉得好像 HGS 可能有一个市场这样。
HGS， 我觉得反而喜欢 HGS， 而且除了美国人喜欢 CDS 在做。上次那个这一出来，经常说他们的还有就是在跑，对，
这个出口的更223你都跑不了。
那个护理师以前都要跑，他跑的还可以讲嘛，都跑。对，就是现在大概我们在。
现在大致上是讲5到以上才能使。
对，美国人讲。
对，但是我看你们做的真的很可爱，尽量这个对。
当时才这样。是吧？
对，因为
现在没在换了，他们就说，假设他将来他 collapse， 后来把身体掉，然后他就会跑出50多级，他不会影响所以我们把完那个 lens， 我们都会放进去。那个不要弄，你要注意到，因为我们都放。像刚刚我讲的，就是库克是3国的，库克4国的，波士顿是3国的样子。对，然后我们有发现或者要进去看到没有位置哦。可是那些 case 后来追查，超导体它也很高的一个。对了，其实有时候他可能也没有啦，所以但是你在爬到最高的时候，没有让做太多事情，你就把它放走。ES 这些我是想来看我们自己测定
那你要正好那个要那时候 case， 那我们都有了，几乎每个礼拜 CDS 是，我也是他比较少做，后来我就干脆，因为我们不能没有 CDS， 后来我就做很多 CDS。然后我们 CDS 现在有个韩国的 EUS， 它10年前以前韩国人发的，结果paper发表完就都没有审，直到最近就拿来做，他们把那个 parameter 做成7个 range。我真过去有 HGS 或者是 CDS， 我可以直接跑，不用带，直接放，不用带，就是7个 range。对，所以那个 state 也有啊，我们做一些可以啊，但是最好是我们没有价的。
这有点难，
因为一个星期，我应该都有了，我这个每个礼拜都会出来，所以我只把一个星期换了，一个礼拜是比较少，这2个星期，2个礼拜。
因为那个 trial 已经做完了，对吧？之前我跟Jonathan那边说有一个 EUS-GJ 的那个临床实验的，
那时候在
对，那时候有蛮多的嘛。
对。
这应该还有，每个礼拜起码有个。
都有啊。CDS， 我比较不喜欢 CDS。其实你看他们在做，外国人他们用西方人他们用口图，你不要说哈雷93好了，直接打。但是你会注意到他们哈雷90他们用口图是出来过，他在 Stanford 做的，那为什么是一开始就会立刻，他都有立刻，就是那个有时候就是这个角度稍微歪一点，上不去。变成说如果我本来是这样爬出来，你可能在面对的时候变成这样，变成一个歪掉，可能进不去。所以 CDS 好像在我很喜欢做。
那个报道要很够。
所以 quarterly dilated 在动脉系列，我觉得是这样。没有人都 OK。收不到的数。就是问题是我刚刚跟他讲，就是我的太久，他会，因为他会 collapse， 他弄完以后他会贴。我们有一个 case， 放没多久，很好的效果，他就马上塞住了，被那个这个部位变成我这样他们就把时间比较好嘛。对啊，就是理由打烧推开了，把它推开了。你们这边都实地做很多那个实验信息，
不会多还好。
一样先压CT，还做像肌肉越来越多，对，肌肉
有点像，就是老实说，这种最好就是 HCA 再加 GJ。
对，因为你们要在这边做了学会要跟其他学会讲，因为听友在问我说为什么其实有 case， 就是因为我们在做外科，然后哪怕的去他不知道，这就是要特别refer要透过从你在做的，对，要我们，
但是因为现在新加坡 GJ 方面有点一般一般，因为之前全部都是，就是说全部都是 gastro 的人，内科的人做啊，现在变成我们的 GJ 有点外科的医生。
他们也是这样去抓，因为去香
港对，
知道你了。
外科的，反正 Jonathan 就是他有做一点，可是他的外科同事他们也是有学 EUS， 他们在做那个同事做 GJ。当然外科做 GJ 已经，因为他们有可以布置之后路，
他们的 case 来嘛，他们是做了980是吧？
有什么事情他们也是自己可以。
这样就很难成长。
对，这是一个现在。
现在都是每次在你的医院里面
对，就是几个医院还好，但是有些比较，说几个 个好像分院他们就开始有这个现象，就是 GJ 这些 EUS 外科内科制作。以前在新加坡起码 EUS 一个本内科，就是 UGI 的 UGI 人学。
我以为外科有在用，
外科比较少。就是我们内科就是从好像radio 从basic 开始学习，就是你学会做球，你才做 FNB， 那你才去学这些 GJ。现在就是有点改变了，就是有些人他去了 Anthony 那边，他学了一些，他就开始做一点。
他们 case 没有很多。
有些时候他们可能就去6个月做了几例过后，就美国人certify 这样 OK。所以我们也是在想，
那边那时候好像比较不开放，现在有个菲律宾的来，快要结束了，叫我放一些机械手指，会你们看那么多应该都自己做的没什么问题。
EUS 这当然没有胖那么小的，我们做的还是。
对啊，但是以后的事情，有的很小，我们也帮不到啊。还是这样。
之前有段时间是做他们在新加坡还要停止售卖，所以我们再找到另外一个公司把它带进来，所以现在起码还有。有一段时间他们本来要在，对，还有一个是我有一个手动贷款，他在拿手动进来，不过一部分他就要代理了，因为用的人不是很多的，因为我们的 free collection 真的很多，99年是这样。HDI 开始有蛮多的时候，他们我们在开始做蛮多例的时候，在官方面突然讲可能要带进来就是这种，因为是差不多给新加坡市场太小了。但是现在又找到这个代理商，应该还好，因为我们有开始像肿瘤科啊，我们或者在推广这个我们讲 EUS 有个帮助。对，可能你可以趁病人还没这么虚弱那个有点开始起的时候，我们就做了，就可能效果会比较好。
跟我们从前都是为了许多事情嘛，但你现在做个 application， 应该说 market。
我们速度其实也是蛮少的，就是1-2年在积累的。我们喝酒人少，开会单一少。
没有体积高的。我们的很多最近好多，而且最厉害的还是除了喝酒以外，体积高的那一种。
我们这几位实际上是真的是不错，那种回过来选是好像感觉。
我觉得是你的基因太厉害了，喝酒都不会。应该是这样子。
没有，因为我是4个儿子，我没有高粱这些儿子。
喝好久啊，
对，我是要吃饭了，大家上下吃吃。
中午别到没有这个。
对。
在左边。
这个有 is that presenter view? How to do presenter view? Oh yeah, use presenter view.
Yeah, I will change for you later.
But it's not presenter view. How do I see my? That one's presenter. Okay, good. Thank you. How are you? Okay. Long time no see.
Long time no see. Very busy.
Yeah.
Just have fever last week, last month, and then this week, then Singapore, then end of April, then Sri Lanka.
Wow.
Also, my helper also take a leave.
You got a kid already, right? Your wife was pregnant.
Yeah.
Now your baby is already how old?
Almost 1 year old.
1 year already, right? Yeah.
Very demanding.
Congratulations.
Always need to
boy or girl?
A girl.
老师我不可以叫你这个了，因为你是我的。
传给珍妮他们。
哦。有点尴尬，我叫你这个。
没有啊，看看。现在要来 check 你的 performance，audit 你的 performance。
他参加了这个 trainer 了，所以他要做 presentation。
没有了。
那不错了，回来就已经可以当 instructor。因为to tell the truth, so for so many years, Singapore don't have a young or new instructor. Always was Lawrence, Chris. 应用 is not about this speed. So always only three. Charlie Su. academia 好像没有那么多，它比较 speech。technique 好像也有啊，那你们这样都 how many years? So many years. New instructor. 像我们台湾的话是几年就要一批，所以我们现在要办海纳的时候，给我们教就很多年轻人是这样做。
所以你们教
会将来也会啊，就是去受训。我们中也是说要去那个 AEG 的那个 TTT， 要去参加 TTT， 参加 TTT 完了以后就是我们说的 instructor。
总会有规划去回去吗？
哎呀，不知道，要是叫他要不要回去，因为第一个就是说那边马靠没有人
啊，对，
很少人。
你叫他回去，你叫永辉回去，
永辉不然他就要拿台湾的 ID 啊，他一拿 ID 他就要去当兵，他就要去那些 service。
所以他现在还没有拿到 ID 吗？
他们没有看你年纪吗？如果你
太早嘞，现在因为我们跟 China 要跟他打仗，他连我这个已经63岁，
他也是有你当兵了。
他在问我从哪是当什么，他人多的时候我们都要去。哇！他人家问我说我都忘记了，不知道我在哪个单位。我已经，
你最好不要跟他说了，还是你可以跟他说你是我只是
不行，他们都调得到，他要真的打仗。
你是做什么？
啊，陆军啊。
陆军啊，
很短了，很短的时间，所以太危险了。所以我叫他不要拿台湾的 ID， 太危险。
但我看新闻，现在那个中配都要遣返回去大陆嘛。
那个就是我们那个现在的 government， 他们很狭 narrow minded， 他们其实没有想到，如果这些中配都不回大陆的话，大陆才比较不打我。 因为大陆人都在台湾，他怎么打？那你现在都把他送回去，那更好打了，因为他的子弹不会打到中国人，所以我不知道我们政府在想什么。对啊，现在很多了，像我们那个我们的政府的员工全部清查，有没有大陆的身份证？现在都有调查，都来喊叫我们要填，说我没有中国大陆的 ID， 大规模。
所以澳门有影响吗？
对。
他好像他在台北很多年了，他就在台湾念医学的嘛。
对。
对。
这个他们现在还没有，我想他们还没有想到这个。还没有想到。像我们的军人的医生，就是军队的医生，他们不可以去香港、澳门。因为中国的土地都不行。晓得。所以现在不要随便到台湾。
可是你6月你在参加你们的会了。
他们都不能来。对，大陆都不能来，不能来6月那一次，我们那个会啊。我好像有一个传说了，就是会有一个很大的 earthquake， 在那个日本、台湾。有没有看那个网络在讲？
对。
7月5号。
对。
所以我跟那个米娅说，我们要不要去？因为上次不是谁吐得一塌糊涂那个亲近农场，是不是？
对。
我赶快去那边 booking 那个 hotel，
那
一天。
多
高啊，很高啊。
更高，比较安全。
我听说已经都被 booking 完了。
7月你就来香港。香港 IDDS 吗？
不是，可是那一次香港有一半没？香港有一半，他们那个传说了，就是说日本大概有1/3的人跟土地不见了，沉下去。台湾、菲律宾跟香港浮起来，然后我们就没有 border。我说那时候你要做第一件做的事情是什么？就是浮起来，对不对？你赶快去找一块地哦，就围起来说这是我的。
这是我的。
以后你就是大富翁。你要画在哪里跟我讲，我画在旁边给你当名字。这是真的啊，因为我的祖先是从大陆来的。他们说他们来的时候在台南那边，他们就去围了一块地，就是围起来，这个
都是我自己的，
都是我们家。
就这样你只要来而已，你说这是我的地。
那时候没有人，那围起来就是他的，就是我们的。所以那时候我回南部，我爸爸就跟我讲说，你现在看过去，再看到那边，从前都是我们的。后来是因为我们政府有一些规定，所以田地要分给别人。所以就没有。
因为他们是国民党军队，最后刚过去台湾。
那时候是有一个政策啦，因为那个时代可能就老师他们没有办法了解，那时候的有钱人有很多地，他们就请一些工人来种田，然后种了田以后钱当然还是归人，然后这个老板再给他钱，可是这个就是永远没有办法翻身啊，就是因为这样，所以那时候毛泽东他打赢了中国的时候，他就解放以后就是有钱人都要把钱拿出来，土地都要拿出来，所以蒋中正是用了一个比较文明的，好像不是这样子，但是基本上也是，他就把土地他就我们叫375减租了。那个政策还有耕者有其田，就是说我请你来帮我做，对不对？可是我要一块地给你去耕。所以我的祖先他们就必须把我的曾祖父 就去把这些田都拿出来，然后看多少钱，政府给还是农民给，然后把人顶都要给那些农民。其实跟毛泽东一样啊，其实是比较文明一点做法。
还好吧，他最少你的曾祖父还是在台湾安老嘛。
啊，对了。
就就是我公公以前就是文革的时候，
文革啊。
对啊，差点就死掉了，好像就关了2个礼拜，但还好他不是太有钱，所以就放过他。
对啊，那时候有钱人很麻烦。
对啊，但其实他不是有钱啊，但因为他有念过书。
念书都不行。对，说都不行。我有一次做那个 taxi driver， 那个 China， 他说他没有读过那个，我们不是在背那个很多的史啊，中国的那个一些书嘛。
唐诗。
因为他遇到文革那段期间，完全不可以去上学，没有学校，没有老师，没有校长，他们只好在家里读。有一阵子。所以后来你逐步就跑到香港。
我公公就是他其实在广东啊，他跟香港本来就很近，他就是游民啊，所以以前其实他常常都来香港，但因为他在香港找不到工作，
杜某比，
所以他就回去，就是回去大陆，对，但后来就是他跟我妈妈还有其他我妈妈这些家人都就来香港。但其实这非常的近，就像台北跟桃园的距离。
他是在那个什么时候来的？是在解放之前还是解放后？
解放后，再来。对。
解放后再来可以跑出来。
对，因为他就是游民嘛。他本来就是船，你就可以。
OK。对。就那是很激烈的。
快开始了。
快开始。
你这个背过来，这个 plate 是什么的？漂亮，这是你们医院的？
是我的医院。
啊，医院的，这么好啊？设计的？
是他们，你可以问Professor Teoh，不是的，他们自己设计的。
这是医院知道了哈。
对。
这可以是这个什么？医生运动，sport。特别的。总医院有做这个吗？主要是。总医院有做这个。
做什么？
没有做。
好像有。You all do EUS-GJ as well, right? SGH, you all doing EUS-GJ as well, right?
Yeah.
Okay.
Okay, so I think we come to the final lecture before we start our hands-on. So Jonathan will share with us how to start on doing EUS-GJ and how to do it better.
Okay. Good afternoon, everyone. Thanks for Prof. Ang and the AEG for giving me this opportunity to speak today. I'm Jonathan and I'm from Sengkang General Hospital. Today, the topic given to me by Prof. Ang is Achieving Excellence in EUS-Guided Gastrojejunostomy. I should probably highlight that the person I learned everything from, EUS-GJ, ERCP, EUS, is sitting right in front of me, Professor Hsiu-Po. When I spent my 1 year in his center, learned a lot of things from him. So I'm very grateful to be able to present to him today as well. On the surface, EUS-GJ might seem like a relatively straightforward procedure, especially in this modern era of electrocautery-enabled lumen opposing stents. In my view, true excellence in performing EUS-GJ comes not just from technical execution, but from thorough preparation and the ability to anticipate and manage any potential complications. So here's a quick overview of what I'll be covering today. I'll start with a brief case presentation to set the stage, and then I'll go through indications and contraindications indications for EUS-GJ, which I believe are important not just for patient selection, but also as part of the informed consent process. Following that, I'll walk through the actual technique, and finally, we'll discuss potential complications and how to manage them effectively. So the patient is just an 84-year-old gentleman with good premorbid function, who presented with nausea and vomiting and significant loss of weight of 5 kilograms over 1 month. A CT scan was done, and that showed a suspicious lesion at the gastric antrum, which is causing gastric outlet obstruction. There was also evidence of tumor spread to the regional lymph nodes, as well as metastasis to the liver and the lungs. So we put in an NG tube to decompress and aspirate the stomach, and then we did an OGD, and then you can see there is a very malignant-looking stricturing mass at the antrum. So despite the narrowing, we could still put a normal OGD through into the duodenum. And when we took biopsies, it confirmed that this patient had HER2-positive adenocarcinoma, which is typically more aggressive and has poorer prognosis. So we presented him at an MDT, and the consensus we reached was for this patient to have chemotherapy, which is for palliative intent. So to manage his gastric outlet obstruction, we discussed 3 options with regards to the patient. So 1 is NG tube insertion, 2 is an endoscopic pyloric duodenal stent, and 3 is a gastrojejunostomy, which can be either done endoscopically or surgically. So I came out with this very brief table summarizing the 3 options that we gave him. So first, let's look at the NGT. As we know, it's quite easy to put one in. You can just do it endoscopically under fluoroscopic guidance. Drawbacks obviously is that it's not very well tolerated to have a tube in your nose for a prolonged period of time. So one study has showed that the median time of failure for an NGT is only about 10 days. So personally, I'll probably reserve an NGT for patients with very limited life expectancy, or those who are very, very concerned about cost. So not really the ideal option for most patients. Next, we look at the middle ground, which is a duodenal stent. Also technically very easy to do, high success rate. In Singapore, it costs us about $1,650, which is about half the price of a LAMS. Randomized trials have shown that when comparing a duodenal stent to a GJ, they have higher rates of intervention at 6 months. So I'll probably tend to offer this for patients in centers which are unable to insert a EUS-GJ, or those who can't afford a LAMS, or those who are too frail to go for surgery. Lastly, for GJs, which is either surgical or endoscopic, both offer durable relief and lower reintervention rates. But EUS-GJ carries a stent misdeployment risk of up to 27%, which is very significant. And if you're not able to salvage these patients endoscopically, it usually means that they have to go for surgery. So personally, I will reserve EUS-GJ for patients who are not fit for surgery and those who are expected to live more than 3 months. So let's look at EUS-GJ versus duodenal stenting. Two retrospective studies that compared them, and both showed that those who went for EUS-GJ had significantly lower rate of recurrence and need for re-intervention compared to those who received duodenal stents. You can see on the study on the right side, they also found significantly higher rate of clinical success in the EUS-GJ group. We all know that Professor Anthony Teoh, who we're privileged to have with us today, led the DRAGO trial, which is a multi-center RCT, comparing EUS-GJ with duodenal stenting in unresectable gastric outlet obstruction. The study showed significantly lower re-intervention rate of 6 months in the EUS-GJ group, quite significant, 4 versus 29%, as well as longer stent patency. There was also no significant differences in 30-day mortality, technical or clinical success, adverse events, or quality of life. So how does EUS-GJ compare to the surgical approach? So I found two multi-center retrospective studies that looked into this. The first found that technical success was slightly lower in the EUS-GJ group compared to surgical GJ. However, EUS-GJ had significantly fewer recurrences and reinterventions, 3 versus 14%. The second study by Perez Miranda et al. Showed that EUS-GJ was associated with significantly fewer adverse events, 12 versus 41% compared to surgery. This meta-analysis comparing EUS-GJ to surgical GJ and enteral stenting, so it showed that EUS-GJ had higher clinical success rates compared to enteral stenting, and no significant difference when compared to surgical GJ. In terms of safety, EUS-GJ was associated with significantly fewer adverse events than surgery, and showed no significant difference in adverse events compared to enteral stenting. So taking all this evidence into account, EUS-GJ is clearly quite a strong option for managing gastric outlet obstruction. Some studies have proposed a GOO grading system, recommending EUS-GJ particularly for patients with GOSS scores of 0 to 1. Of course, malignant GOO remains a well-established indication, but the ESGA has begun to examine more open indications for EUS-GJ, such as benign causes in patients who are poor surgical candidates. So in these kind of cases where you put in Axios or a lumen opposing stent for benign causes, they will recommend removing the stent once the underlying cause is resolved. Benign causes described in the literature include chronic pancreatitis, pyloric stenosis, SMA syndrome, and afferent loop syndrome. Notably, ESGA specifically endorses EUS-GJ for SMA syndrome as well. So let's talk about the contraindications for EUS-guided gastrojejunostomy. Obviously, those who are unfit for sedation or endoscopy will be contraindicated. In practice, I also wouldn't recommend EUS-GJ for patients with a life expectancy of less than 3 months, because the expected benefit is likely limited, and this cutoff is also supported by several studies as well. There are also technical factors that can make the procedure risky or difficult. So these include perigastric varices, massive ascites, diffuse gastric wall infiltration, and extensive peritoneal metastasis. So these are all listed as contraindications in the ESG guidelines as well. What are the risks of EUS-guided gastrojejunostomy? I think the main thing to be very wary about is stent misdeployment. In the study by Gendor et al., they found the stent misdeployment rate to be as high as about 9.85%. And obviously, these occur in the early learning curve phase of the procedure. They even propose a classification system for the types of LAM misdeployment. So as you can see, type 1 is when you deploy through the stomach wall but not go through the jejunum. Type 2 is when you manage to go through the stomach but you actually puncture the jejunum and the stent is deployed between the stomach and the peritoneum. Type 3 is deployment between the peritoneum and the jejunum and there's a gastric defect. And type 4 is when you deploy between the stomach and the colon. So including stent misdeployment, this systemic review and meta-analysis examining all adverse events overall found the complication rate to be about 11 to 12%. And these adverse events included bleeding, perforation, peritonitis, stent migration, and of course stent misdeployment, which we just discussed. Then looking at the learning curve for EUS-guided GJ, obviously most of them occur in the early learning phase. By analyzing procedure times, they found that you need 25 cases to reach proficiency and around 40 cases to achieve mastery. So this really highlights the importance of training, supervision, and case selection during the initial learning phase. So now on to the technique of doing a EUS-GJ. Yeah, you all can see that there are 6 described methods. It's quite hard to see, sorry, but method A, they are saying that on the top left-hand corner is a freehand technique, which I wouldn't recommend because as we know, the jejunum is very mobile, very hard to do it this way. Method B is a retrograde approach, so it means puncturing the jejunum back from the stomach. But obviously this depends on being able to get the scope distal enough, which isn't always possible. And method C involves puncturing the jejunum and threading a wire back into the stomach to confirm placement. So A, B, and C, I think not very commonly done nowadays. Nowadays we do more of D, E, and F. So all of these techniques, they begin with first passing a wire across the obstruction into the jejunum. And it's just a matter of finding your target. So method D is using a balloon catheter as the EUS target. Method E is the technique taught to me by Professor Wang. So basically we put a nasal-biliary tube into the jejunum and then we pump in a lot of water to distend the bowel, and that forms the target for our puncture. Lastly, F is the double balloon system, like in the E-pass technique used in Japan to isolate the segment of jejunum. In terms of the stent we use, personally I use the Boston hot axios in 15 or 20 millimeter sizes. So to prepare my patient for EUS-GJ, personally, because I'm still kind of in the learning phase myself, so I prefer to have an anesthetist there to support me. Patient ideally should be intubated because you foresee these patients, they have gastric outlet obstruction and you're planning to be pumping in a lot of water, so there's a very high risk of aspiration. I like to do this in OT in case there is stent misdeployment. In case I cannot salvage this endoscopically, I might need to have a surgical conversion. But of course, if OT isn't available, you can also do this in endoscopy room. I put my patient supine, and of course, you have the C-arm for fluoroscopy. And lastly, I give prophylactic antibiotics before the procedure as standard cover. So in terms of the equipment I prepare, I divide it into the nasal-biliary catheter insertion and the puncture with the hot axios. So for the nasal-biliary catheter insertion, I'll use a 1T scope because this will allow me to directly put in the NJT into the instrument channel, make it a lot easier. But if I'm unable to pass the obstruction, I'll switch to a slimmer scope, of course. Then I'll use a guide wire and a balloon catheter to help me navigate into the jejunum. Nasal-biliary catheter, I'll use a Cook 7 French nasal-biliary drain. Then as I said, for the lamps, I'll use a hot axial stent. Obviously, I'll be using a linear oblique echo endoscope. My cautery settings, I use AutoCut Effect 3 at 100 watts. And then to prepare the water also, we will mix it with some methadone blue. And then we'll give glucagon later on to immobilize the bowel right before we puncture. So the first part was very dry, I apologize, but now we're going to have some videos. So the patient I mentioned earlier in the end opted for EUS-guided gastrojejunostomy. So step 1, obviously we try to scope as far as possible. And then over here, I'm trying to insert the guide wire. Normally I'll put a balloon catheter as well to add an element of stiffness. And also I can inflate the balloon to try to change my angle of approach. So once I'm able to get the wire past the ligament or treats, I will then insert the ENVD directly through the channel of the 1T scope. So I'm just flushing in some contrast to confirm my placement there. And then we then will start to pump in a lot of water into the jejunal loop. And once we do that, we change the EUS scope. So over here, okay, we're finding the loop of bowel. Then you can see the water being flushed in by the ENVD. And then we puncture the jejunal wall. you can see the bubbles from the cautery. Then we open the distal flange, pull it back to tend the distal flange. Then we change to endoscopic view, deploying the proximal flange while in the channel and withdrawing the scope. So that was just a brief video going through everything, but I'll just go through a few more details with each step. So step 1, as I said, we insert the nasobiliary tube. Ideally, we use the 1T scope. I mean, I keep emphasizing this point, but I feel it makes things a lot easier if you can insert the EMBD directly through the scope channel. If not, if you can't do that, we might have to switch to a pediatric endoscope if you can't get past the obstruction. But that creates a lot of steps trying to exchange the endoscope with the EMBD. So I found in my experience, this leads to like the wire slipping out or the EMBD tube coiling, you know, in the mouth or in the stomach. So it makes things a lot more challenging. So once I'm in, I use fluoroscopy with a guide wire and a balloon catheter to position my wire into the ligament of treats. And then I inject contrast to confirm my position is correct. Then step 2 is locating the jejunal loop under EUS guidance. So I'll switch to EUS scope and then I'll inject a bolus of glucagon to kind of freeze the bowel. And then I begin pumping in lots of blue water into the jejunum to distend the bowel as much as possible. So in terms of the target, I look for one that's as close to the EUS as possible. So you want a loop of jejunum which is less than 1 centimeter away. Sometimes the jejunal loop might be very far away due to ascites. So I would recommend that you try to drain the ascites before you attempt to do a EUS-GJ in that kind of scenario. So in Taiwan, I actually saw Professor Wang, they actually on table, they'll use the EUS scope to try to aspirate the ascites. But of course, you know, the amount you can aspirate is quite limited. So ideally, you should try to drain them as much as possible before the procedure. Then in terms of the ideal loop also, you want a loop which has sufficient runway for you to deploy your axial stent. So ideally, you should have the distal wall of the jejunum about 4 centimeters away from your EUS probe. And then the best is if you have like a loop which is sloping away like this, so that you know that when you puncture, you know, you have a lot of runway to go along. So step 3 is the creation of the gastric jejunal tract. This step is very important because once you burn a hole through the jejunum, it's the so-called point of no return. So under diathermy, you advance your hot axial catheter into the jejunum. Then because of the cauterization, you should see bubbles, which will confirm that you're inside. Once you're in the jejunal loop, be very careful to take your foot off the pedal of the diathermy, because if you keep advancing, you might burn the distal wall. Once you are in, I'll push the catheter in slightly more just to ensure my position in the lumen. I would like to highlight a very important point here, which is to resist the urge to put in a guide wire once you've done this, because by doing so, you can actually push away the jejunal loop, causing your catheter to dislodge out of the small bowel, leading to misdeployment. So resist the urge to put in a wire at this point, okay? Step 4 is deployment of the distal flange into the jejunum. So once you know your catheter is fairly deep, you deploy the distal flange. If you want to put the guide wire now, now will be a good time, because once you have your distal flange there, it can kind of help to, you know, ensure your position in the jejunum and you're less likely to slip out. Once the distal flange is open, you then pull back the catheter and you kind of see this American football shape, knowing that you're sufficiently tented. Then the step 5 is deployment of the proximal flange in the stomach. So I'll switch to my endoscopic view. Then you deploy the flange in the scope channel. Just now, Professor Anthony Teoh said the old technique was to see this black marker, which we don't do nowadays. Nowadays, we try to deploy in the channel so that we minimize the effect, the risk of deploying the proximal flange outside of the stomach. So you just withdraw the scope, adjust your big wheel, and then you should see the proximal flange slip up. And if you've done it correctly, you should see a gush of blue water confirming that you're in the jejunum. Personally, I don't like to dilate the axial tract afterwards. as there's a very small but real risk of stent distortion during dilation. So before we start to celebrate, I observed this in Taiwan, but you should be very careful about removing the EMBD tube, because what can sometimes happen is you can see the tail of the EMBD tube is hooked, and what can happen is that it can actually hook around the axios, so that if you just blindly pull out the EMBD tube, it can actually cause your stent to dislodge. So you should probably do this under fluoroscopic guidance. And what Professor Wang he taught me was that if you see this happen, what you can do is you can put a guide wire into the EMBD to help to straighten the hook tip of the tube. And once it's straightened, you can just slowly withdraw your EMBD so that it doesn't dislodge your stent. So when it comes back to my patient, I like to highlight a very amusing adverse event my patient had. So you can see that, his urine actually turned green. So that's a result of all the blue water I pumped in. And because of that, my patient had a bit of dilutional hyponatremia because of all the water I put in. But thankfully it resolved on its own after about a day. So I think we should just be mindful of how much water we pump in when we do this, in case someone, starts to get hyponatremia. So our patient did quite okay. He went home 3 days later. Unfortunately, he passed away of pneumonia about 3 months after that. So now I'll just go through my rationale for a few technical decisions when performing an EUS-GJ. So first of all is antibiotic prophylaxis. There are no official guidelines saying that this is required. However, when they surveyed American endosonographers, they said 86% of them said that you should probably give it before the procedure. So because of this general consensus, that's what I chose to do as well. This is another technical point which I highlighted before, but it's whether to put in the guide wire during EUS-GJ creation. And the concern here is that by putting in the guide wire, you might displace the axial stent out of the jejunum. So when they surveyed these American endosonographers again, most of them, 71%, agreed that you probably shouldn't put in a wire. However, a third of them felt that it should be okay as long as you deploy the distal flange first before you put in the wire. Then as to whether you should dilate the lamb's tract or not, opinion is split down the middle. No clear general consensus was made. Whether to put in the double pigtail stent or not, most of them felt there was no need to. In terms of the size also, most of them agreed, larger is probably better, so 15 to 20 millimeters should be okay. So looking at all of that, they came up with this very clear EUS-GJ protocol, which is, for my own practice, is a good frame of reference, especially for those who want to build up some experience with this technique to refer to. So here's a video of one of the cases I did, which I think we all can learn from. So I already put in the EMBD tube, and here I'm preparing to put in my hot axials. So you can see I'm puncturing now, and I'm in the jejunum. You can see the bubbles there. Okay, but for this case, I made the mistake of actually putting in a wire. Oh, sorry. How do I need to pause the video? Okay, how do I? Okay. Yeah. So, yeah, I actually made the mistake of putting in a wire. Oh, crap. Sorry. How do I do this? I made a mistake of putting in a wire, and as a result, I think I slipped out into the peritoneum. You'll see in the next one. Yeah, so it looks like I'm in the peritoneum here, right? Yeah, so at this point, I want to pause just to poll the audience. Who here would abandon the procedure and do a CT scan and call the surgeon? And the other option is, who here would proceed to deploy the lamps and, full steam ahead? So who would abandon procedure? Can I have a show of hands? So everyone here will deploy the lamps, even though you think you're in the peritoneum. Okay, so for those who are online, no one put up their hands. I think no one is sure. So for this case, I actually had a friend of mine who's a surgeon with me in the room. And then we had this very quick discussion of what to do. So our rationale was that if we were to abandon procedure now, this patient already has a puncture of the jejunum, he has a puncture of the stomach. I mean, we can probably try to salvage it through the wire, okay, but there is a chance that, you know, he's going to need surgery lah. Whereas if we deployed the lamps now, you know, we have the wire in there, you know, if we're lucky, maybe it is in the jejunum, but if we're not lucky, we can try to endoscopic salvage this patient. So with that, oh sorry, we start from the beginning again. So with that, we actually decided to just deploy the lamps anyway. So you're going to see what happened after that. Yeah, so sorry, once again, you know, I'm putting in my wire. And then you can see it's in a very funny position now. It doesn't look like it's in the jejunum. So here I'm deploying the distal flange. Yeah, it looks like it's outside, right? So endoscopic view now, deploying the proximal flange. So you can see water looks a bit blue, so I was a bit happy. Yeah, it looks a bit blue, right? So I thought, okay, we're doing quite okay. However, you can see there's some peritoneal fat there. So this is a type 2 stent misdeployment. Yeah. So what should we do if the EUS-GJ is misdeployed? So in the study by Gendel et al. Again, you know, what you should do really depends on the type of misdeployment. So for type 1, which is deployment between the stomach and the peritoneum with no puncture of the jejunum, quite straightforward. All you probably need to do is just take out your axios and you can clip up the defect or do some endoscopic suturing. For types 2 and 3, which involve the jejunum, if the guide wire is still in place, you can try to salvage it by placing a bridging fully covered metal stent or a second lamps. However, if there's no wire, you know, it's a bit more difficult. You might have to do like a notes kind of procedure if you have the expertise available. For type 4, where you deploy your axios between the stomach and the colon, obviously that's more complex. I think these patients will probably need, you know, some form of surgery lah. So back to my patient. So I put in a very slim nasogastroscope, and then I dilated the tract of the axios to allow my scope to go in. So what I was trying to do was I was trying to put my my scope into the peritoneum, and then try to see where this guide wire that I had there was leading to. Hopefully you're still, you know, going to the jejunum, then I can try to access that and put a bridging stent. So now you can see we're scoping inside the peritoneum. So you can imagine I was a bit nervous. So I'm trying to find the loop of jejunum, but I couldn't really find it. I think it was buried under some peritoneal fat. And I was trying to pump in, you know, more of the blue water to see if you can see water, you know, see where the water is coming from lah. But long and short of it, we couldn't find where the loop of jejunum was. So this patient had to go for surgery. We brought him there and he had a laparoscopic GJ. The hot axios was found in the posterior stomach wall, and there was a small bowel perforation. The surgeon told me actually it was quite easy for him because there were 2 holes there for him to just suture, to just staple together. So it's quite a straightforward surgical GJ for them. And fortunately for this patient, patient did quite well, went home, you know, managed to tolerate diet. And I think it helps to communicate this possible risk of conversion beforehand to the patient, which we did. So they were actually quite okay. So that was the, I would say, negative example of how to salvage that. But here's the positive example. So here's a video by Dr. Amy Tyberg's group of how they salvage a misdeployed lamps. So the first part is just the deployment of the lamps over the wire. So they're deploying the lamps here. And then they're dilating the tract. So you can see it's a type 2 misdeployment again. That's the loop of jejunum with some peritoneal fat. So what they did next is they went in with a very double channel therapeutic endoscope. So through one channel, they put in a rat-2 forceps to grasp the jejunal wall, bring it close to the scope. And through the other channel, they put in a needle knife to try to access the jejunal loop. Then from there, they're putting in the wire into the jejunal loop and coiling it. And they're confirming the position with some contrast. Then here they're putting in a tubular metal stent to help the bridge between the stomach, the hot axials and the jejunum. So final contrast studies, it looks like, you know, there's no leakage and it's essentially a GJ. So in summary, EUS-GJ is effective and safe option for managing gastric outlet obstruction, whether from malignant or benign causes. However, that said, it's a very technically complex procedure involving multiple critical steps, and there's quite a steep learning curve, not just for the endoscopist, but for the entire endoscopy team. So while outcomes are generally good, the most significant risk remains stent misdeployment, which can occur in a notable proportion of cases. So it's quite essential that I think we should be very well prepared and be able to execute, any form of salvage if we identify a misdeployment early, and to understand the different types and be ready to, deal with them. So with that, actually, that's the end of my presentation. Take any questions?
I think Jing Han has some experience in this too, right? You'd like to share some tips with us?
I think the tip is to have a surgeon. Be a surgeon.
So I think disclaimer is I'm a surgeon. So I don't have a lot of experience. I think my technique is largely the same as Professor Wang and same as Jonathan's. I think a few tips that I've learned so far is that nowadays when I puncture, I get the system to stay on the saddle so that I can maintain bowel circulation, fluid so that it's moving. So this is one of the modifications I did since coming back from Hong Kong. I think the other lesson that we have to learn is that perhaps mouth deployments are not as scary. I think in medical school and things like that, we always follow the dogma that you can't have a hole in the bowel, but I think there's some increasing evidence that even for type 2 mouth deployments, sometimes you can remove the stent, especially if you haven't fully deployed it, or if you puncture through but you think that you lost position, then it's probably okay to remove the stent delivery device and puncture at somewhere that is quite nearby. Of course, I think you have judicious, maybe fast attention for a little bit more, go slow with these monitor cerebral exams, but I think there's increasing evidence that patients not always need to have a lobotomy when you have a failed. These are the learning points that I had over the last 1 year.
In the past, so you showed 6 techniques, and I think probably on a practical basis, we use the one that you shared where you. So that means to say for yourself, you also use the pump to delegate the. You attach a pump to the. The nasal tube so that it continuously can inflate and therefore the thing won't collapse, right?
Yeah.
And you're saying that you use free hand to puncture and then deploy. Free hand puncturing.
Yeah, correct.
So in the past, so if let's say the same thing happened, then there will not be any guide wire, right?
Yes, correct. As in, I won't put a guide wire
anymore. So the potential benefit outweighs the risk of guide wire.
Yes, correct.
Because those examples you showed, use the guide wire to sort of navigate and try to go down.
Oh no, sorry. I punctured first, and then I put in a guide wire, just as an insurance policy. After that, yeah.
After the stent is in.
Before the stent was deployed, before the proximal, the distal flange was deployed.
Yeah, so you think we still put guide wire after that? For deployment or don't put it out?
I'm saying you shouldn't put at all, but if you want to put it, you should put it when you first deploy the distal flange.
The distal flange.
Yeah.
Yeah, so that you not push it away, right?
Correct. Yeah.
Okay. Chris, you want to?
Yeah. So I think our technique is very similar. So use saline, not water, because if it's water, you may end up with water intoxication, 2 liters, whatever it is. That's one thing. The second thing we do is we backload the guide wire over into the axial system. And you have to do it from front to back because it's just very hard to put it around the correct way. Although there are some people who have published ways of doing it, adapting little needles to go into that small hole. When you backload, you want to avoid pushing the target small bowel away. So freehand puncture with the hot system, and as Jonathan says, deploy the distal flange first. And once you've done that, you hold it back and confirm that you're in the right place. You put your guide wire in, and that serves as your safety net, as it were, for you to deploy the proximal flange by the standard technique of intra-channel deployment. I think the other, sorry, I wanted to say this also, but the other thing that we've had trouble with, and this happened recently with another case, was that if you want to be as certain as possible that your target small bowel is right next to the stomach, because if you are a little bit too far away, you find out that you run out of space. Your tip cannot go far down enough. And then even if you're in, you cannot deploy your distal flange safely. And then it slips out. So this is, I think one thing that we have to be very certain about before we start a deployment is that, or rather even the puncture, is that you have the minimum distance possible between the target small bowel and your stomach as well, to make sure that you really don't run out of space with being able to protrude your delivery system.
Thanks, Chris, Jonathan and China for sharing. I think it's very useful for us to learn from the experience of others so that we can avoid all these pitfalls and so that our very first case will be a little bit less uneventful. I think, are there any more final questions? If not, we move to the last part of our course. Okay, so if not, then maybe Andrew, you have to brief. Okay, so I can finish it, yes.
We just show the, you want to let the online participants go off?
Yes. So I think for those who join us online, thank you very much. I hope you found it useful. And so now we move on to the actual hands-on session for those who are on site here. And so thank you for joining us. I think we can lock off already.